Hi, everyone. Good morning. I think we're going to get started. It's wonderful to see everyone. So I want to, first of all, thank you, everyone, for coming. I know you have a busy Saturday usually, and so to spend it here with us, it means a lot, and I really appreciate it. And so this is our first patient and family kidney cancer symposium through Yale and the Cure Network, rather. And I want to say a few things. I think the first thing is I don't want to speak for too long. I could ramble for a while, but I want to say why I think we should be here, what I'm hoping for today, and then also some thank yous, because this was a big effort to kind of get everyone together. So the first is, why are we here? Why are we spending a Saturday together? And I think there's probably a couple of reasons in my mind. The first is really to learn. I think I'm so grateful for the speakers. Some have traveled here from quite far, some from locally, but really an incredible collections of surgeons, of radiation doctors, nutritionists, geneticists, medical oncologists, patient advocates. We really have a tremendous lineup. And so I think this is really a chance to ask your questions, to really learn from a tremendous group of people. I always sort of think back, most of what I do is just focused on being driven from what comes from patients. And so I think back to a patient of mine, international patient of mine who, every time I saw him and every time I would think about a new treatment, a new therapy, I'd sort of go into these details about the risks and the benefits and all these details, and he'd sort of break it down. Okay, just tell me, is the juice worth the squeeze? Very, very simply. And so I think what you'll hear today is a lot of that information. What are the things that are really up and coming in kidney cancer, where we are now? What are the things we've really built at Yale? And really become more informed so that you have those conversations with your family members, with your doctors. You can really help to assess that question, is the juice worth the squeeze? The second sort of goal of today, at least in my mind, is really hopefully bring everyone together. And that's separate from a little bit of the faculty and colleagues that are at the table. I think of so many patients I have, and I have a very skewed perspective because my entire life is kidney cancer. I only see patients with kidney cancer. I run a laboratory that studies kidney cancer. And so it was actually really good sort of level setting for me. I had a patient who had traveled from out of state and sort of said to me at one point, kidney cancer feels like a really lonely disease. I said, what do you mean? I'm sort of immune to that. I see this every time I'm in clinic. And they say, you see all these things like breast cancer walks, you see all these things in the community, and you don't necessarily see this in the same way for kidney cancer. I think that really is, starting to change thanks to tremendous efforts from a lot of people, including Dina, who's here, in terms of raising awareness and building community. But it still can feel like a lonely disease. And so I think bringing people together in a room who are going through different challenges, different struggles, but also different successes, and to be able to really build that community is one of my sort of hopes for today. And so hopefully we're going to have a great lineup for you today, again, ranging from surgery to medical oncology to everything else. And the last thing I want to do, not ramble too long, is to thank so many people for making this day possible. So first of all, the team at Yale, Renee and Emily, who really helped to organize this together with Brooke, and so many people at the Cure Network, colleagues from Exelixis who provided an unrestricted educational grant, our speakers who are here with us, spending their Saturday to share their knowledge, traveling from afar, and I think most importantly, all of you who I know are looking outside on this beautiful Saturday and spending it inside with us in order to be able to participate and learn. So thank you all so much. So with that, I think we're going to get started. Our first set of speakers are Dr. Alam and Dr. Ghali. They're going to speak to us today about small renal masses, and I'll let them take it away.
All right. It's very good to be here and to be with you. Thank you so much. It's such an honor to be invited to chat with you. Thanks, Dr. Braun and the organizers. I'm Dr. Ghali. I'm Fed Ghali. I'm a urologist here at Yale. And Dr. Alam, you want to introduce yourself?
Good morning. I'm Dr. Muneeb, also a urologic oncologist here at Yale.
And we're going to just talk to you a little bit about small renal masses. And I think that the story of small renal masses is quite interesting. I think it's quite emblematic of a larger movement in oncology and in kidney cancer care, which is to start to, instead of just looking at patients as, somebody has a kidney cancer, they present to your office and then you say, oh, look, there's a tumor in the kidney. The story of small renal masses is really about trying to break down and understand, are all of these patients the same? Do they all need the same treatments, or can we start to insert a little bit of nuance? And this is kind of a narrative that's developed over many decades now. So this is us. These are our glamour shots here. So what is small? So a small renal mass generally is defined as tumor 4 centimeters or smaller. Sometimes this can be extended a little bit. As you can imagine, measuring the size of a tumor is actually not quite like measuring your height. Sometimes it's actually a little bit more difficult to get an exact measurement of a tumor. But there are many, many, many patients who are diagnosed with kidney masses, and many of these tumors are very small. One of the things that I'm going to discuss a little bit is that most of small renal masses here are going to be incidentally detected, meaning that we find them when we're looking for something else or we're looking for nondescript symptoms that we can't really pin down to one location or another, like flank pain or so on. We were just talking outside before starting this conversation about, classically we sort of think of these tumors as asymptomatic. I think that's kind of the consensus, but that's even being challenged now, whether some of the symptoms that patients are experiencing may be linked to these. But by and large, we sort of think of these as tumors we find almost by accident or incidentally, really. And classically, back in the 60s and 70s, if you found a tumor in the kidney, the solution was you remove that kidney. That was the answer, is that you remove the tumor. And that's really quite understandable. I mean, we look at this now with a little bit of, through the retrospectoscope, we think back and we say, that's crazy that's how we approach these. But it made a lot of sense if there was not a lot of evidence that, that there were safe alternatives, that's what you did. And these are 3 figures. I'm going to just walk through a little bit of, this is some of the early evidence. This is kind of a classic paper written by a guy called Gil Welch, who's a public health epidemiologist up at Dartmouth, or was up at Dartmouth. This is kind of a classic paper that demonstrated this incidental diagnosis of small renal masses. What you can see in the far left here is this is a heat map of the United States, and the red and the lighter colors are showing the basically the use of imaging, CT scans, and mostly CT scans, although later MRIs as well. And what you can see is that there's a big difference in imaging use across the country. Some parts of the country use imaging a lot, and some countries are sort of cold spots. Like you can see here, for example, in the Pacific Northwest, there were areas. You can see here in the Southwest, whereas in the Southeast, in Southern California, in New England, where we are, imaging was used a lot more. And what they found in this paper is that if you look at the risk of a patient having a kidney cancer surgery, plotted against their risk of getting a CT scan, what you could see is the very nice classic linear relationship here. In other words, the more CT scans were being done, the more likely a patient was to have a kidney surgery. And this was part of the early evidence building the case that we're finding these because we're doing more CT scans, and that was leading us to do a lot of surgery. Now, you might say, well, that's well and good. We're finding more cancers. We're doing more surgeries to remove cancers. That makes a lot of sense. And this is really, I think, a clever figure that was shown in the same paper on the very far right, which is what you can see here is the mortality rate over time. So this is the number of patients who are dying of kidney cancer, succumbing to their disease ultimately. And what you could see is over all of those decades in the past. So this is now, this paper was published in the late 2010s. But that line was very, very stable. What you could see in the yellow line above is that the number of surgeries people were having was increasing significantly. And this really hints at a very clear problem, which is that for a lot of patients, we were doing a lot of surgery for small renal masses and not really affecting the ultimate outcome for patients in a significant way. And this really, I think this was part of a lot of evidence that was building that we can safely de-escalate therapy for a lot of patients. And this has now become, part of the case that we use to try to say, well, maybe we can de-escalate a little bit. So historically, small renal masses were universally treated. What we find is that there are a lot of reasons why maybe that doesn't make a lot of sense for very small renal masses. One is that many of these renal masses can be benign. And so we can find that, we don't always need to treat them because sometimes we remove them and they're not cancerous. Many of them grow very slowly or change very slowly over time. And then, of course, there are competing risks. Many of our patients have other problems that should take precedence over their small renal mass. And so we built a more nuanced, over years, we built a more nuanced approach to small renal masses that is not a one-size-fits-all for patients. And so this is what this looks like. And so we're going to talk through some of these options today, but small renal masses, we sometimes find biopsy to be helpful. We won't dive too much into that, but that is sometimes a useful tool. And then otherwise, there are generally several approaches. And many times we will start with this active surveillance sort of in appreciation for this idea that many masses don't actually require surgery and we can maybe slow down a little bit. We don't have to go right to surgery. We don't have to go right to doing procedures. Of course, as many of you will know, sometimes we do. And we'll talk a little bit about partial nephrectomy and the surgical approach to removing kidney masses, which, like I say, many of you have some experience with, and how this procedure has evolved also over the years and become a better procedure for patients. And of course, newer procedures have also been used, ablation and radiation. And so validating active surveillance. So this is just to nod to one of the key pieces of evidence we use to understand the trajectory of patients on active surveillance. This is a registry study. This is called the DISARM registry study. This was led out of the Johns Hopkins group, which looked at patients who had small renal masses and were enrolled. So they were consented and enrolled in this registry. And they followed this group of patients. And this was a large set of patients. And what they found is that for many, many, many patients with renal masses that are small like this, over 50% of them, I think it was 65% of them, never required anything done to those small renal masses. They lived out their whole life and could safely be monitored, and we were able to safely avoid surgery for them. And you might say, well, if you're not treating these kidney masses, did those patients suffer a negative side effect? Did the cancer grow or spread or go somewhere else? And the answer is no. This is 12-year cancer-specific survival, meaning the risk of patients living 12 years out and never dying of that kidney cancer. And it was 99.3% in this study, meaning that almost everybody in this group was able to safely go on active surveillance as an initial approach for small renal masses. And some of them eventually did need surgery or did need other therapies. So it's not that it just means that none of them had any procedures, but at least as a start, we were able to avoid surgery for a lot of patients, and still these patients did very, very, very well. These are some figures from that study that I won't belabor, but what you can see here, the long and short of it is that comparing folks who went on treatment immediately versus those who had surveillance as an initial strategy, specifically in this long figure here, what you can see is those lines are right on top of each other. Those patients did very, very well. And so the size of the tumor is a really big factor here, like I'd mentioned. So the risk of the tumor actually being cancerous and very aggressive increases as the tumor size increases. So very, very small tumors, ones that are less than a centimeter big, almost a coin flip chance of being cancerous. As it gets bigger, that number goes up, and up to 80% for tumors that are around 4 centimeters. And so we focus on de-escalation in patients who have very small tumors that aren't growing rapidly. And of course, we can start to use even other tools like MRIs and other things to help differentiate those patients. One of the main things that we like to avoid, or we'd hope to avoid in taking care of patients with kidney masses, is the cancer leaving the kidney and going to somewhere else. This is, of course, a key event that's worth doing everything we can to prevent it because it's a different disease at that state. And what you can see here is the risk of metastasis. This is percentage risk of metastasis by size. And again, one of the things that's really important to note is that in these really small sizes, the risk of metastasis is quite small. And so it highlights this group of patients where we can provide nuance in how we care for them. Whereas as it gets larger and, those of us who take care of patients, as soon as it gets above a certain thresholds, we will start to say, this is not one that we are comfortable watching anymore because of figures like this. All right, I'm going to hand it over to Dr. Allen here.
All right, good morning. Thank you, Dr. Ghali. So I certainly have many patients in my practice with small renal tumors who are on active surveillance. Active surveillance, I think, is a really important strategy, and we've adopted a lot of what we've learned from other cancer types. But we do know that some patients will benefit from intervention, and there are different reasons for that. Sometimes we pursue these interventions right at the beginning. Sometimes we proceed with a period of active surveillance, and ultimately that patient may need an intervention for one reason or another, typically due to the tumor getting larger. We know that close to 25% to 30% of patients may end up getting a treatment, and that can be because the tumor grew or because there's anxiety about getting scans frequently, and that's okay. So we do have a lot of really effective and typically minimally invasive approaches now. And we really try to use a patient-oriented approach to choose a treatment that's really going to be the best one, depending on the individual patient. So, as a disclosure, I'm not an interventional radiologist, but we do counsel on some of the techniques that they use to treat these kidney tumors, and one of these is thermal ablation. So, this is a technique that's been used for many different cancer types, many different disease types over time. And when I talk to patients about ablation, I basically try to kind of explain that the general approach is to use a type of energy. And they're all different types of energy. We can be using ultrasound or microwave. We can use cryoablation, which is where you freeze the tumor. But the ultimate goal is to really target the tumor itself, typically using imaging, and to destroy the cancer cells in their location while preserving the entire rest of the kidney. And this approach has a really excellent success rate. So greater than 85% success rate, typically for tumors less than 3 centimeters. The interventional radiologists have gotten very skilled at performing these procedures, doing these ablations in very challenging locations. And even with bigger tumors, we've seen some good success. There are some limitations. The best way to approach these tumors is usually through a patient's back. And so kidney tumors that are on the back of the kidney are much more accessible than kidney tumors on the front of the kidney. And we also do get a little worried about tumors that are approaching the center of the kidney, where the blood vessels lie and where the ureter lies. So that's the structure that drains the urine from the kidney, because we can potentially see some problems. But there are many tumors that are amenable to this. And I do send a lot of my patients for ablation, and they've had very good outcomes. You can see here the 15-year cancer-specific survival rate, close to 100% in solitary small renal mass cases. So I think a very effective approach for these small kidney tumors. So partial nephrectomy. So this is kind of me and Dr. Ghali and the other surgeons in the department. This is kind of our job. Partial nephrectomy started to really evolve kind of in the late 80s and 90s. In the beginning, it was really challenged as an approach to the treatment of kidney cancer because it was felt that we really needed to remove the whole kidney to treat these tumors. But in the modern era, it's really considered a standard approach to the treatment of a small kidney tumor. And more, as we develop techniques and become comfortable, we're even approaching some larger tumors using partial nephrectomy. And the real goal is to preserve as much healthy kidney as possible, because we know we can have very good outcomes even when we're able to leave much of the healthy kidney behind. So as compared to things like ablation, which can have very good outcomes, we do consider this the most definitive approach, and outcomes can be quite good. The risk of recurrence is in the single-digit percentages. These procedures do come with some risks. So in the bottom right there, you can see a picture of the robotic surgical instruments that we use. We almost always attempt to approach these surgeries through a minimally invasive approach. And we've evolved from laparoscopic surgery to robotic surgery. So most of the surgeons here in the department are doing robotic partial nephrectomy. Certainly for bigger tumors, once they get quite large, that can be challenging. But for these tumors, really feel like that's a standard. And part of the reason is number one, it allows us to really be nimble inside of the patient and to make good decisions from a surgical standpoint, but also the recovery is excellent. Typically, patients spend only 1 to 2 days in the hospital. They're back on their feet the next day, they're eating, they're moving around. There's some limitations in terms of lifting heavy objects at home, but generally patients are kind of able to get back to their lives very quickly. And so we feel like this is a nice approach. I will point out that there are some risks associated with this, as with any surgery. The major ones we worry about are bleeding. The vast majority of patients will not experience any need for a blood transfusion. And then a urine leak. So some of these tumors can get quite deep into the kidney, and they can actually approach the area of the kidney that drains urine. So the kidneys filter the blood and create urine, and that drains into the center portion of the kidney called the collecting system. And so on occasion, we can enter into that collecting system, making sure that we remove the tumor adequately. Almost always we're able to close that area and it doesn't cause a problem. A urine leak is not typically a life-threatening issue, but it can be a nuisance to deal with. But again, this is quite rare. So we feel that this is a really great approach to treating these small kidney tumors. Again, I won't claim to be an expert here, and we'll have a nice talk in a little bit about the use of radiation to treat kidney tumors. So this is really an evolving approach. Historically, radiation really was not used regularly to treat small kidney tumors, but I think it's something that is going to become more commonplace as we see the literature evolve. And you may read about it as you start reading about kidney cancer online and in the literature as an evolving approach. So what is SBRT? So on the right, top right there, basically what happens is a radiation oncologist really sort of plans out the therapy so that they can really target the tumor that they're interested in. So if you look on the way far right over here, you can see that the radiation oncologist here has outlined the kidney in blue, but is really trying to target and focus the energy of the radiation in the center of that mass to preserve kidney function. And so this is a great option for patients who may have baseline chronic kidney disease or who may not be surgical candidates. The outcomes are relatively good, but we really need more data to kind of support this use in regular practice. So there was one study recently published. It was known as the Fast Track study. It was a small group of patients, less than 100 patients with about a year of follow-up, but the outcomes were very favorable. So I tell patients that we're optimistic about this approach, but we really need more data before we support its regular use. But I have sent a few patients for radiation therapy, knowing that I can have favorable outcomes in patients who have kidney tumors that I really need to be treated with a minimally invasive approach. So the purpose of this slide is really to highlight that our approach to kidney tumors needs to be personalized. One way that we're starting to use personalized medicine in kidney cancer is through genetics and genomics. There was a lot of work done at the NCI down in Bethesda, Maryland, to study the genomics and genetics of kidney cancer. And out of that work came the description of many cancer-associated syndromes that help us to not only understand the biology of kidney tumors, but to make decisions about how we're going to treat a patient's kidney cancer. And so particularly for my younger patients, the guidelines kind of define young as less than age 46. I do get genetic testing because I do want to know if there's potentially a genetic marker that could help me take care of these patients. And I won't go into this table in too much detail. There's a lot of information here, other than to say that because the biology of these tumors is known, we can really sort of tailor our approach. So some of these tumors, unfortunately, tend to be more aggressive. And because of that, our approach to them tends to be more aggressive. In some cases, maybe we might not perform a partial nephrectomy. We may remove the whole kidney. But in other cases, we may watch the tumors even as they're growing, knowing that at some point we may need to remove them later with the goal of preserving their kidney function. As we move forward, I think we've made a lot of strides in kidney cancer. As Dr. Ghali alluded to, we came from a place where every kidney tumor, was treated with open surgery. Patients were getting large incisions. They were staying in the hospital for a long time. Some of these could be life-threatening operations for patients who might not even perhaps need a surgery. So we've come a long way, but we're also optimistic about the future and continuing to improve on the ways that we're treating these tumors. Dr. Ghali alluded to size, which is really a great clinical marker for trying to figure out the biology of these tumors. But in very rare cases, we have seen small kidney tumors that act aggressively. And so we really want to know which of those tumors we really need to go after. One promising marker of interest is called KIM1, kidney injury molecule 1. This was a molecule that circulates in the bloodstream. It was originally identified for patients with kidney disease to try to figure out if we can determine the prognosis of patients with kidney disease. But some very smart people learned that KIM1 could actually be used as a marker of kidney cancer. And we're starting to study how to use this in clinical trials to determine if a patient may need treatment. We're starting to use molecular risk stratification a lot more. Basically, this is when we have information about the tumor's genomics or gene expression, and we can understand based on studies that we're doing in the lab and in clinical trials whether or not these tumors may need to be treated. And I think a really promising approach and something that will be really nice for patients is to improve our ability to image these tumors. We typically have three modalities of imaging that we rely on, being ultrasound, MRI, and CT scan. All of them are really nice and really effective, but I think that we can do better. And so we're starting to use PET scans a lot more. So a PET scan is basically like a CT scan, but it has a very specific marker associated with it that lights up in a unique way. And that marker has a spectrum of how strong the signal can be. And so different types of markers can help us look at kidney tumors in different ways. And so using PET scans that were studied in other diseases like sestamibi scans or PSMA PET scans, the latter being used in prostate cancer, are really showing a lot of promise in our ability to distinguish between benign and malignant tumors. And there's a very nice large trial looking at a marker of kidney cancer known as CA9, which is associated with the biology, particularly of clear cell kidney cancer, which is the most common kind. And it really helps us to identify tumors that may perhaps look like kidney cancer on a CT scan, but are in fact benign. And so we're hoping to really bring these types of imaging modalities into the clinic so that we can make better decisions for our patients. And then, of course, as I alluded to earlier, this is really multidisciplinary care that's required to take care of kidney cancer. So I'm often speaking, giving Dr. Braun a call on the phone or speaking with my radiation oncologist colleagues or interventional radiology colleagues. Pathologists are incredibly important to really make sure that we're nailing the diagnosis. All of these team members are very important. So it's, again, not the days of showing up at your surgeon, being signed up for surgery, and that's it. We try to get everybody involved because particularly as things become easier in terms of communication, we think it's important to get multiple opinions before we make a decision. So all of these people really are involved, even in the setting of a small renal tumor. So just to kind of conclude here, we really use the size and growth kinetics to guide the approach. It's important to treat the whole patient when we're deciding between active surveillance or ablation or partial nephrectomy or other types of modalities for treatment. We want to take into consideration the patient's comorbidities, what's going on in their life, what's important to them in terms of their goals, so that we can make a shared decision. We're continuing to develop less invasive options. One that you may hear about in the near future is something called histotripsy, which is where we use ultrasound really to target these tumors, something that we're trying to understand a little bit better in the laboratory as well. And then, of course, we want to discover new biomarkers, ways to identify these kidney cancers, and ways to learn how these kidney cancers could potentially be aggressive so we know when to act early. So thank you so much for your time. Thanks, Dr. Ghali. And yeah.
We're going to have a panel session just after the first set. We'll have a chance to ask questions from everyone. I've been so great. I moved to Yale about 4 years ago. I've been so grateful to have such incredible colleagues like Dr. Alam, Dr. Kenney, Dr. Ghali. I used to have patients who came to me and they'd say, I went to the surgeon. They said, "Oh, surgery is my only option. That's the only thing that I can do." And I said, "Well, that sort of makes sense. You go to the butcher and you ask for their opinion on produce and on vegetables and fruit, and they're going to recommend the meat." But since I've come here, they really are not only technically incredibly skilled, but so wonderfully thoughtful about how to approach these often complicated situations, and that's been incredibly helpful on the medical oncology side. So I didn't have enough coffee in the morning, and I forgot to introduce two of the most important people, which are really my co-hosts for today, which are Dr. Kenney and Dr. Kluger. So welcome them. So they're really the ones that I think together have helped really elevate and build the program for many, many years. And I wanted to have Dr. Kluger maybe give a few words on just the history of the kidney cancer program here at Yale, how it's developed incredibly over the last couple of decades. And then I'll introduce Dr. Kenney, who's going to speak to us about some of the capabilities here when it comes to more complex surgeries.
Thank you so much, Dr. Braun. And I just want to echo the thanks to everyone for coming out on this beautiful day and spending time with us. So I'm Harriet Kluger. I'm a medical oncologist. I guess by definition that we just heard, I'm no longer young. But what I want to tell you about is what kidney cancer was like when I was young, below age 46. So when I first joined the faculty at Yale as an oncologist in 2002, there really was no program. At the time, we had one surgeon, John Kohlberg, who did most of the kidney cancer cases. He's an amazing surgeon. His nickname was JC, no coincidence. And at some point, he really wanted to make something more of the program that we have or had. At the time, we were seeing approximately 4 patients a week with metastatic kidney cancer, and sadly, there really was nothing for us to do. Most people went on trials of agents that we didn't think were necessarily going to work. There was a useless form of chemotherapy that we gave, and we would give a drug called interferon in the clinic, which made people feel kind of sick. So in around 2004, my colleague at the time, Dr. Schnoll, and I set up the cytokine program, where we gave patients a regimen that was actually quite toxic, high-dose interleukin-2. And approximately 10% of patients had long-term survival, including someone that I just saw last Wednesday in clinic, who we treated in around 2006 or 2007, and she's still doing well and off therapy. So high-dose interleukin-2 became both the bane of our existence and our pride and joy. It was very intense and very difficult, and not everybody was actually robust enough to do it. And at approximately that time, 2004 and 5, we started to give drugs that targeted the vascular system. In other words, the blood vessels that supply the kidney tumors, trying to strangle them a little bit from the nutrients. And that did help a little bit. So median survival for metastatic kidney cancer went up from around 12 months to 18 months at around that point. At this juncture, though, I just want to say many years later, we have a group of people here. We have how many urologists that do kidney surgeries? At least 4 or 5. We have an oncology group of 5. And we have a patient volume in the oncology clinic, at least, it's gone up from those 4 patients a week to well over 50. So part of that is because we built up a program, and the program includes research. Our first kidney cancer grant was awarded to us in 2007. And we now have 5 or 6, 7, I don't know, David probably knows the numbers better than I do, but we have people studying vascularity, metabolism of cells, in different kinds of immune cells in the kidney tumor, all sorts of different avenues. And we're starting to come together now more and more so that we can deliver therapies in the clinic. Later on, you'll be hearing about some of the novel therapies that we're delivering or we're offering. Some of them actually results of work that was done in the labs at Yale. So a lot has been done. I really am proud of the program that has been built here, not taking credit because we've got Dr. Kenney and Dr. Braun and everybody here in the room is part of this. It's not one person who can do all of this. And of course, more important than anything else, it's all our patients and our patient advocates who've helped us along the way. And so we thank you for being partners with us in this journey.
And so with that, just wanted to introduce Dr. Kenney, who's my other co-host, and again, really helped to build this program. Has been my close colleague since I've moved here. I'm so grateful to have had you speak today.
Thanks. Good morning, everyone. Thank you so much for the opportunity to be here with you. The green button, I assume? Okay. So The topic I was assigned today is tackling the tough cases. And my first reaction to that was we tell our interns and junior residents that there's no such thing as a simple case. And I think that's true. And so by saying the tough cases, I don't think we really intend to minimize, every single diagnosis, every single case matters. But there are times where certain tumors or certain patients face very particularly difficult challenges. So I don't have any disclosures other than to say I do have some biases, and I am biased in favor of patients doing really well. I am biased in favor of data. I do have a bias and belief that we probably overestimate the quality of our data sometimes, and we probably underestimate the opinions and needs of our patients sometimes as a field. So those, I think, are probably my main disclosures. I don't have any financial ones. So what is meant by tough cases? So what we're going to talk about is things like tumor factors, right? So that's large tumors, so very large tumors, or tumors in very difficult locations. We talk about anatomic complexity, and this is particularly important for partial nephrectomy. And so where a tumor is located can impact the difficulty and the risks of a surgical approach. It was mentioned earlier whether a tumor is involving the center of the kidney, where there's blood vessels and urine collecting system. Kidney tumors can also grow into veins and what we call tumor thrombus. It's a misnomer, right? So thrombus means blood clot. This is not blood clot, although sometimes there can be blood clot along with it. This is actually tumor growing into and filling up a vein, and that can grow into the large vein in the abdomen called the inferior vena cava and can even grow up to the heart. Kidney tumors sometimes can also involve adjacent organs, so the organs near the kidney. All those factors of the tumor itself can make it a tough operation or a tough case to treat. Prior treatment also can impact whether something counts as a difficult operation or a difficult tumor to treat. So someone who has extensive prior surgical history, either on the kidney or in other organs, someone who's had ablation of a kidney tumor before can sometimes increase the complexity of surgery. Systemic therapy, so immunotherapies prior to surgery, we know increase the risk of scarring, and that can increase the duration of surgery and some of the other surgical risks. Some other patient-specific risk factors, kind of separating the patient from their tumor, is other surgical illness, other illnesses, other comorbidities. We have to take into account the status of someone's heart and their lungs and the other factors that can increase the risks of surgery. Frailty is an incredibly important concept for our patients. So we do have patients who have kidney tumors and they are frail. And as Dr. Kluger mentioned, there were patients who were not great candidates for IL-2 because it was such a difficult treatment. There are patients who may not be great candidates for surgery if they are also frail. We also think about kidney disease. And so if someone has reduced kidney function or just one kidney rather than two, the consequences of surgery can be pretty significant, and that does impact our decision-making. So when I think of surgical innovation, what I really think about is innovation that has changed how we treat patients, the safety level of our treatments, and how well we can treat them overall. So some big picture themes. One is less is more. And so what do I mean by that? What's already been covered is this idea of active surveillance. And it's not just active surveillance, but that less is more, but also partial nephrectomy, right? If we can preserve kidney function or preserve an organ, we generally try to. A minimally invasive approach, which pure laparoscopy is still commonly employed, but very often here we are using a robotic approach. And less is more is true, except for when more is more. And so one of our jobs is to try to figure out when that is true, when we should have a less is more approach and when we should have a more is more approach. When I think of more is more for challenging tumors, what I'm thinking about is the entire team of people that we can bring to bear to help our patients. And I also think about the role of surgery and systemic therapy. And my talk is focusing on surgery. There are plenty of options, as we've discussed, that I'm not going to be reviewing, things like ablation and radiation. It was mentioned this idea of the regional variation in imaging, incidental diagnosis, the role for active surveillance. it makes me think of this Maslow quote. I suppose it's tempting if the only tool you have is a hammer is to treat everything as if it were a nail. And I think one of the most important surgical innovations is not doing small incisions, but doing no incision. And if I had to rank surgical innovations that have happened during my career, it's that. It's avoiding surgery for people who don't need it. And that is active surveillance for the small renal mass. But I think more subtly, for our patients who have metastatic disease, there's a concept called cytoreductive nephrectomy. So removing the kidney when kidney cancer has spread. And for some patients, it's an absolutely essential part of their treatment. But for some patients, that surgery can also harm them. And one of the most important things we can do is try to identify who those patients are to avoid surgery in people who don't benefit from it. There was an important study called Carmina, and this is an older study now, done with a medication that we don't use as a single agent anymore. But in that trial, where patients were treated with kidney cancer that had spread elsewhere, there were two groups of patients: people who were treated with medication alone, and then people who were treated with surgery and medication. And the group who had their kidneys removed, almost 20% of them were unable to then go on and actually receive systemic therapy, the medications that they really needed. And so one of our innovations, right, is not just avoiding incisions in people who have a small kidney mass that can be safely observed, but trying to avoid surgery in people who may be harmed by it, right? People who have metastatic disease, a systemic disease that needs to be treated. Cytoreductive nephrectomy still has an important role. We have an open trial that we're investigating the role of cytoreductive nephrectomy in patients who are being first treated with medication, and then we assess their imaging response, and then after about 3 months of treatment, and then are being randomized to either surgery followed by additional treatment or medication or discontinued medication without surgery. Kidney cancer surgery has really evolved a lot. The radical nephrectomy, so removing the kidney, was really first described back in the 50s by Robeson, and that's removing the kidney, the surrounding lymph nodes, the adrenal gland. And in that era, partial nephrectomy was only done in what we call like imperative cases, meaning that it had to be done because the person only had one kidney, for instance. And innovation starting in the 90s, early 2000s, was sparing the adrenal gland. So as the quality of imaging improved, and we could show with confidence that there was no involvement of the adrenal gland, we got to leave the adrenal gland in place. Similarly, studies have been done around the role of lymphadenectomy, removing lymph nodes. And if the lymph nodes look normal on imaging, we don't have to remove them. Then we started doing elective partial nephrectomy. So partial nephrectomy for people who have intact kidney function or two kidneys, but removing the tumor, leaving the rest of the kidney in place in order to preserve renal function, in order to reduce the consequences of the surgery itself on their kidney function. Laparoscopy was introduced in the early 90s, from kind of 2010s to current. We're doing increased complexity laparoscopic and robotic surgery now, enhanced recovery after surgery. So this is not surgery, but this is how we take care of patients around the time of surgery. So it used to be, and it still is at some centers, that patients have to alter their diet the day before surgery, have nothing to eat or drink after midnight. Patients come in dehydrated. That can change the amount of fluids we give in the operating room. If we give a lot of fluids in the operating room, people's bowels get swollen, slows down bowel recovery. Oftentimes, we used to not allow people to eat and drink until they were passing gas. Many of you may have heard of that or experienced that. Now we allow people to have food and drink really on the day of surgery. Non-opioid pain medications, so use of nerve blocks is a really important adjunct to help improve people's surgical experience. Preventing complications. A lot of work has been done around reducing the risk of surgical site infection, reducing the risk of blood clot, which is VTE, venous thromboembolism. And then the integration of surgery and systemic therapy is an area of very active ongoing work. There are times where someone has localized disease. This is rare that someone has localized disease, and we also treat them with medication to perhaps shrink that tumor to make it possible to do a partial nephrectomy. We also now have good data in support of adjuvant therapy for some of our patients. So these are patients who've had surgery, no evidence of cancer spread elsewhere, who would then go on immune treatment to reduce the chance of cancer recurrence. And there's some data, although still controversial, that it may also save lives. And then coordinating the surgery to remove the kidney in patients who have metastatic disease along with systemic therapy. I think about three big factors, and I share these with my patients when we're talking about decision making. Controlling the cancer is often very high on the list of goals. Sparing kidney function, reducing risks, improving recovery, improving quality of life in the immediate perioperative period as people are recovering. These are areas where we need to do less, right? Where we employ surveillance, use partial nephrectomy instead of radical nephrectomy, using ablation and other nephron-sparing approaches, doing the minimally invasive or robotic approaches. For cancer control, these are areas where we need to do more for some patients, right? We're coordinating with other treatment modalities. These similar images were shown earlier. This is the most current surgical robot we use here. It's the Da Vinci 5. The biggest innovation in my mind is on that little arm console, I can put my cell phone and it charges while you do the surgery. This is very similar to the XI robot, which was before that, which is very similar to the SI, which is very similar to the S. I'm not totally convinced that all of the surgical innovation and this like Lamborghini that we get to drive in the operating room is necessarily driving outcomes, but there are subtle improvements. This console, from an ergonomics standpoint, is a dramatic improvement over what we were using just a year or two ago. C-spine injury is very common among the surgeons. My hope is focus on this, focus on ergonomics in the operating room will really help. Some of the instruments that we can use, we have needle drivers, we have energy instruments, we have staplers, we have clip appliers. There's an enormous array of instruments that we can use and bring to bear. But really, it's not the actual robot, right? Pure laparoscopy can be a perfectly good approach. The minimally invasive approach, the benefits, it's not just the size of the incisions, but it's the consequences of the incisions, right? Avoiding a flank incision, avoiding a surgery on people's ribs or removing ribs, avoiding flank bulges, avoiding the pain that comes from large incisions if we can. Faster recovery, a more complete recovery, we hope. Reduced blood loss, reduced infection risk. There is, with the robot, better magnification. It's a 3D as opposed to a 2D view. And then there's plenty of good fine control, which allows for very delicate reconstruction. So what do we use the robot for at Yale? And one of the things I would emphasize is surgery is very much still an artisanal type of field. The most important thing for surgeons to do and for patients to have is if a surgeon is more comfortable with an open approach, if the surgeon feels that that is where their expertise lies, that's probably the most important factor in determining someone's surgical outcome. But here we use the robot for even very complicated partial nephrectomy, and these are tumors that are very deep in the kidney or very much in the center of the kidney. Partial nephrectomy even for small tumors that involve the vein or other high tumor stage. We do partial nephrectomy robotically here for patients who only have one kidney and that kidney has a tumor in it, and even for multiple tumors. Radical nephrectomy is removal of the entire kidney and the fat around it. It used to be that very large tumors almost always had to be done with open surgery. That is no longer the case. We also do robotic surgery for cytoreductive nephrectomy, and even when removal of organs nearby is required. And this can be surgery on the bowels, like the colon, or the adrenal gland, the pancreas, the spleen, the liver, and surgery on the inferior vena cava, which very rarely can involve actual removal of the vena cava. That's very rarely indicated, but can be safely done robotically. We also remove lymph nodes in the area around the kidney robotically, and that requires very advanced techniques to fully mobilize that big vein and the aorta. And then we can remove tumor from within that big vein robotically. Not in all cases, but in many, and in these days, in most. We also do what's referred to, and this is a term that I'm not a big fan of, but what we call salvage surgery. And what that is surgery after someone has already had treatment. Patients can develop a significant amount of scar. It used to be felt that after multiple prior operations on the kidney that the open approach was required. That is really not the case. The robotic approach can be used in all of these instances. Even for, as I mentioned, for very high complexity partial nephrectomy, you can see that the center of the kidney has veins, it has arteries, it has urine collecting system. And when tumors are centrally located in the kidney, the consequences of removing the tumor and also leaving a functional kidney, the consequences of surgery in terms of complication can be real. Bleeding after surgery or impacting the urine collecting system, urine leaking from the kidney. The surgical robot, I think, is actually very nicely, it's a very nice tool for partial nephrectomy that's high complexity, given the visualization, the very fine instrumentation, and the robot can recapitulate essentially all of the movements of the human wrist. So it really allows for very fine, delicate work, allowing complex partial nephrectomy. Radical nephrectomy, again, is removal of the kidney, the fat around it, fat around here, and then when indicated, removal. When radical nephrectomy, when necessary, is a wonderful operation. If we can do partial nephrectomy, we ideally would like to leave the kidney in place. Most often these days at our center, robotic surgery is employed over open. This, I do think open surgery still has a role. The video that you're seeing there is an ultrasound of the heart, with the black area here being blood flow in the heart. This is the septum running down the center of the heart, and this gray thing here is the kidney up the inferior into the heart, and you can see it moving with every heartbeat. I think this is still best approached with open surgery when it's at that level. I also think open surgery is probably the best approach for very large kidney tumors where just functionally we're not able to approach it robotically. I wanted to warn those who don't want to. The next slide does have a surgical video. It's a robotic surgical video. It passed muster with my wife, who is not a surgeon, but I did want to warn you in case you didn't want to look. So what this shows is that this is the retroperitoneum robotically, and so the retroperitoneum is the area around the kidney. If you can see it here, this kind of blue structure is the inferior vena cava. This is the aorta pumping here. That is the divided renal artery with a clip on it. This is where the right kidney used to be. This is the crus of the diaphragm. In there is the chest. That is the liver up here. What this shows is robotically having removed the kidney, done an entire lymph node dissection, something that would be very high complexity open surgery, requiring a large incision, a long hospital stay. These patients typically are ready to go home the next day. And the largest incision is just as large as it needs to be to remove the surgical specimen. This is the vena cava completely mobilized. The kidney vein going from the left kidney is here, but showing a very full and complete dissection, really recapitulating open surgery. So bringing to bear an entire team is really important. So the idea of more is more. The number one person on the team obviously is the patient, and not just the patient, but their support system. When I think about telehealth, I think about telehealth also being a patient who has their phone on during a visit with someone else listening in if their friend or family member couldn't come with them. The primary care clinicians. I'm talking about like the surgical team, right? The primary care clinician is a really important member of this team. Patients really should have a good sense of what is happening with the rest of their health. Their primary care clinician should be an important partner. Medical oncology, decision-making around when is surgery a good idea, and should surgery happen now? Should it happen in the future? Should we wait to decide? The anesthesia team, particularly the use of a peripheral nerve block. So around the time of surgery can make a huge difference. The nursing team in the clinic, the medical assistants, the nursing team in the operating room, the administrative team that works really hard to get surgery scheduled, the pharmacy teams, the supply chain teams that procure all those instruments, the trainees who are involved, the scrub technicians who are in the operating room. I think on TV, we see them just handing instruments and it seems like, well, that's a pretty not like very difficult role. The scrub technicians are an incredibly important part of the team. And then obviously the surgeons. So that's urologists, yes, but also cardiac surgeons, liver surgeons, colorectal surgeons, thoracic surgeons. I think one of the best things about a general hospital, right, is that when I need to work with a cardiac surgeon and the patient needs to have open heart surgery and go on a heart-lung machine, the team that is doing that every single day. We do heart transplants, we do liver transplants. When we need a liver surgeon to help with doing surgery with the liver, those surgeons are extraordinarily experienced. So we can bring to bear an enormous amount of talent and skill and expertise in the service of our patients. But I think we also can't forget some of the other aspects of care that happen around the perioperative period. The chaplains that people see while they're in the hospital, social work, food and nutrition, physical therapy. I think we have a lot of work still to do in these areas to support our patients. But how to tackle the tough cases, it is a team that truly does start with the patient. And we can't forget the pathologists who are going to look at all of that, the information the tissue we give them from the operating room to tell us what it was. So I think we are going to continue to make surgery better, right? Incisions will be smaller, recovery will be faster, things will be easier, our instruments will be more precise, but alone, I do not think that will improve the chance of us curing patients through improved surgery. This is the annual rates of cancer deaths up until 2020. And you can see plotted on here, I put the first robotic kidney cancer surgery, the first robotic IVC tumor thrombectomy, the first single port kidney cancer surgery. So doing robotic surgery just through one small incision. And there's absolutely zero reason to think that those surgical innovations have contributed at all to this modest decline we're seeing in kidney cancer death. But what does contribute is the innovation that's happening with medications, with drug treatment for our patients who have metastatic disease. And surgery, in my opinion, is most properly viewed as one component of very well coordinated care for our patients with metastatic disease. And like, why does this matter so much? For our patients with localized disease, or what we think is localized disease, a portion of them do not have localized disease and eventually will recur. So when we are taking care of patients with localized disease, we need to be thinking about those who are at risk of recurrence. And there are different theories as to why that happens, why imaging is normal, but patients will have a recurrence. And sometimes that's because there's metastatic disease already, or because there are tumor cells that have disseminated and are lying quiescent, a portion of which will stay dormant perhaps forever, and some which will escape dormancy. If we were to think of surgery as being just a simple tool for patients with localized disease, I think we would be doing our patients a real disservice. Systemic disease requires systemic treatment. There's a wonderful survey that happens, and there's more than 1,000 patients responded to a survey in terms of ranking important outcomes. The number one important outcome for patients in this survey was complete response. The second, durability of response. When we think about adjuvant therapy, right? So as a surgeon, I'm thinking for my patients with localized disease, I know a portion of them may recur. Let's send them for medication to try to reduce the chance of it coming back. Historically, much of our data was based on something called disease-free survival, right? So how long will someone be cancer-free, right? The number one outcome, though, that people really care about is complete response. So all of these other downsides of additional treatment that, well, we may be treating people that it may not come back in, or we may decrease people's quality of life with the treatment. Treatment toxicity, the cost of treatment. The treatment may not work. And then if we treat someone and it doesn't work, well, what do we do next? it's clear that patients want cure. The data we now have for adjuvant therapy that demonstrates improvement in overall survival really seems to push the the balance in favor of adjuvant therapy for appropriately selected patients. And we need to keep listening to patients and what patients want, and design our trials and our interventions to help people achieve their own individual goals. So in summary, less is more. Active surveillance, judicious selection for patients for cytoreductive nephrectomy, using partial nephrectomy and nephron-sparing approaches like ablation whenever possible, doing minimally invasive surgery when it's needed, including for really complicated situations, and less is more except for when more is more. And that is when we need a big team to help, and where we integrate surgery and systemic therapy to help people achieve their goals.
The panel and Dr. Alam and Ghali as well, just the panel. And then we have a patient joining us, Mr. Curry, I believe. If you're able to come up as well, bring a seat over. And then this is really a chance to be interactive. So the hope is a chance for all of you to ask questions. I'm going to shuffle around. Oh, perfect. Chance to shuttle around and ask any questions you might have of our panel of surgeons, medical oncologists, and then a wonderful patient as well who's volunteered to kind of share his experience as well. Maybe while people are thinking about questions, not to put you on the spot, Mr. Curry, but I might just ask a little bit about your kind of journey to Yale and then what you did.
I'm coming up on about 9 months, and I had one of the incidental detections so I had a chest CT for something else, and a doctor thought to say, everything looks fine here. What's that? And turned out that there was a fairly sizable tumor on my left kidney. I had no symptoms. I had no awareness that anything was wrong. But the medical team said, let's follow up on that. They did. And because of the factors that sort of happened at the very end of July, beginning of August, by September, I had surgery with Dr. Alam. In my case, I will say it's interesting to hear all of the discussions, because the care team that helped me very much went through, this is what we're thinking and this is why. These are our options and this is what we're thinking and this is why. And really walked me through to get to something that, as was discussed, is pretty traditional care, which is I had an open radical nephrectomy, but I was completely on board, and I knew that the alternatives had been considered. So far, everything I've been very fortunate in the way that my care and post-surgical management has progressed, and I'm very, very fortunate, feeling very, very lucky to have both learned it all about what was going on, but secondarily to have happened into a community of medical professionals who were really thoughtful, and at a time when there were options, and I felt like we'd gone through the options, starting with what's the least we can do that accomplishes the purpose, and moved up that way.
That's wonderful. Thank you so much for joining us. We'll open up to questions from the group. Oh,
just described. Oh, thank you. Have you had any other treatment beyond aggressive monitoring since you had your full nephrectomy?
Fortunately, no. The nephrectomy, part of the decision for the full nephrectomy was the tumor was large and it was unclear what else would be involved, and it really seemed, I felt it was part of my decision to do that. The surgery the report afterwards was that they looked around in there for a while and felt that that the surgery had been successful. I have had scans since then. I'm obviously working with a nephrologist about moving forward without that kidney. But I think it had to do as much as anything with the particular form of renal cell carcinoma, that some of the approaches. And this was discussed with me, some of the approaches that I had a different form of renal cell carcinoma might have been indicated were known not to particularly at this point be helpful in my case. So, again, we had the discussions, which I felt was really helpful, but it seemed clear that in my particular instance, that the monitoring was really the most productive and least invasive, the least always thinking about what the benefit is, not, well, we do this in some cases, but in your case, this doesn't necessarily play out. So we're going to keep a careful eye on it, but we're not going to do things that we aren't pretty confident are going to offer a benefit.
Can I ask one more question?
Yes, please.
Of Dr. Kenney. Thank you for your talk. It was extremely informative, and I am grateful for that. At Yale, are all urologists who might do a radical nephrectomy referring patients to the team to have all of the input about what the follow-up should be?
I think it's a wonderful question. And so when I think of Yale, so I wear two hats. I'm a kidney cancer surgeon, but I'm also an administrator. And so I help run the ambulatory offices for Yale New Haven Health System and Yale Medicine, Northeast Medical Group in New York, Connecticut, and Rhode Island. And what I can tell you is that many times, cancer care is delivered in the community close to patients' homes, not just at Yale, but really across our country. And so what does that mean? That means that many patients who are having radical nephrectomy, open radical nephrectomy, laparoscopic radical nephrectomy, robotic radical nephrectomy, are having it in the community and not necessarily all at one academic medical center. That's not been something that's really been instituted across the country. There are some countries that have centralized and very intentionally certain cancer care, particularly rare cancer care. And that's not something that's happened here. And so in our health system, what seems to happen is very complicated cases will be referred into New Haven. Sometimes patients will self-select and come to New Haven, but very often the care is being delivered in the community. And I think our surgeons in general have really good judgment. There are not IVC tumor thrombectomies happening in the community hospitals. High complexity partial nephrectomy and solitary kidneys is not happening in the community hospitals. Those complex cases really do get centralized. We do have a tumor board, which I think is a wonderful thing, where we have central discussion of cases. There is centralized pathology review that happens that I think is also very, very helpful, but not all of the care is centralized now.
Yeah, first, I'd like to thank you for your information. It was very helpful. I'd like to know if there is any progress in immunotherapy, and is that something that is a treatment for kidney cancer?
So thank you. That's a great question. The next couple of talks are going to actually focus on that. So I think maybe we can revisit that question in the next discussion. Is that okay?
I think that's a big part of our enthusiasm at Yale on the research and medicine front is really trying to generate the next wave of immunotherapy. So we'll talk a lot about it.
Hello, I just want two things. First, to thank everyone, the whole team, for all the expertise you do in the multidisciplinary approach and how thoughtful and careful you are with the patient focus and doing what's necessary, but not beyond that. So thank you all. It's just amazing care. Secondly, I just had a question, which may or may not be appropriate at this stage, but the interplay between the surgical stage and the systemic treatment stage, and in particular in a case where there is a need for, say, a radical nephrectomy, or someone has a single kidney, to what degree does that impact the options down the road for systemic therapy, immunotherapy, or chemotherapy?
So there are some cancers where kidney and some cancer treatments where kidney function is really essential. And so we can think like there's certain chemotherapy agents like cisplatin or platinum-based chemotherapy. People really need to have excellent kidney function. For urothelial cancers of the upper urinary tract, so of the tumors of the urine collecting system, that's a really essential consideration, and we will make decisions around timing of treatment based on preservation of kidney function so that people can receive certain treatments. For renal cell carcinoma, the majority of the treatments that we're giving from a systemic standpoint, the overall renal function is much less consequential. And so we're not really making treatment decisions in terms of timing of surgery or systemic therapy based on someone's existing renal function. All of that said, patients who progress to needing dialysis is a very significant change, and that can really impact people's treatment decisions.
Other questions?
Hi, Drs. Ghali and Alam. I think you talked about a strategy of sort of a wait and see. I mean, more sophisticated than that, but like letting active monitoring. You know, as a layperson, I don't really understand how metastasis works, but the first thing that comes in my mind is the longer it's in there, the more likely it is for cells to leave. You did have a cell about size and metastasis, but can you say more about how you get comfortable and how you decide whether things are okay to leave and why?
Sure, that's I think a really important question. I think it kind of comes from two places. The first being sort of our clinical understanding of these tumors, understanding their natural behavior. There have been many studies over time by people who are very interested in this, who have followed patients out for long periods of time. Dr. Ghali mentioned the DISARM trial. So in that trial, they took a large group of patients with tumors less than 4 centimeters. They divided them up and they followed them over time. Half of those patients basically did active surveillance. So they got regular imaging tests and they were seeing their doctors every 3 to 6 months typically. So they were followed very closely. And the other half, they went right away and they got an intervention, whether that was an ablation or a surgery. And so that's where a lot of those numbers come out, because when we followed those patients 10, 15 years down the line, we saw that the vast majority of them were not dying from kidney cancer. That number was close to 1%. And so these sort of studies helped us to really understand that from a clinical standpoint, it's safe to watch these. Now, some patients may feel like, well, 1% is not acceptable for me. And so that's when it becomes a patient-specific decision. I think the other sort of component of this is understanding the biology of these kidney tumors. There's been a lot of work done by very smart people in the laboratory studying these kidney tumors. I think one interesting finding is that to go from just a single cancer cell to one of these visible small kidney tumors that we see on a CT, maybe by accident, that can take up to 7 years. And so we understand that the trajectory of the sort of changes that happens to the biology of these abnormal cells, these cancer cells, that takes a long time to happen. And so by just really understanding the biology of this particular cancer type, we feel confident that we know how these tumors in general are going to behave. Now, this is where moving forward, understanding a little bit more about the specific biology of an individual patient's tumor can be helpful, because that might not always be the case, but we know in the majority of cases, that's how these tumors tend to behave.
I just want to jump in. I totally agree. But I think one of the things that's important to avoid is the idea that there's a right approach, right? And what I mean by that is, like, I think when we have a variety of different treatment approaches, very often the conversation is, well, which one's the right one, right? And the right one is the one that's right for patients. And we know from questions that have been asked of patients, right? We know that anxiety, and I think it's even unfair to call it anxiety, right? It is a very real confrontation with the risk of having something in you that may spread, right? We know that that's the number one reason people will choose active treatment, right? And if you think about it, right, when people are diagnosed with a small kidney mass and they're enrolling in the disarm registry, a significant portion of patients choose treatment first. That's not a randomized study. That's people are choosing. And then if you look at the people who have chosen surveillance, the number one reason they come off surveillance is not that it grew, and it's not that it grew fast. The most common reason people come off of surveillance is by choice. And so I think of active surveillance as the number one treatment option for patients with small renal masses. I just do, and it's a bias. Why? Because I believe in first do no harm. And the most important thing I think of is not that cancer-specific survival is greater than 99%, and it's that there's no detectable difference in survival between people who had treatment up front and people who delayed, right? I think that's the important thing, right? You're not losing something, at least we don't have any data that says you are, by saying, I may do something in the future, but I know I don't need to do it now, right? April 15th is coming up. Everyone has to pay their taxes by April 15th, right? Active surveillance is kind of like saying you get to pay your taxes next year, or maybe the year after, or the year after that, and there's not going to be a penalty to pay. That, to me, is the idea. It's not a permanent choice. You get to choose something else. But that idea, and again, I don't love calling it anxiety, but that concern, that fear, it's real, and it's a quality of life concern. And if surgery can treat that, or ablation, or more frequent imaging, then that's what we do.
Time for one more question. Please.
Thank you so much for explaining active surveillance. That is extremely important, especially when you hear that you may have a small mass or something's wrong and that nothing's going to be done in a patient's head. They may think that, this doctor is not treating me right, or they're minimizing my concerns. But this is just really, really informative. And for Todd, I just want to ask, how's your quality of life today?
Excellent. I feel a bit like a fake because I did not have any symptoms going into it. It was entirely incidental, aside from having surgery. And I would just say, when they read to you the risks of surgery, all of a sudden the active surveillance becomes a very appealing option, if it is an option. But in my care, I have been very, very fortunate that things have, at every step of the way, in my case, speaking only for my case, felt like they've gone sort of as well as they could. Of the available options, things worked out. And so I feel very, very fortunate. And I would just say, that doesn't mean I'm not going in 2 weeks to have my next round of scans, because we're in the active surveillance stage post-operatively, just to see what comes up, because with my cancer, I'm not a good candidate for some of these other treatments. But so for me, that's really what I'm hanging on to, and feeling very lucky. And I'm a teacher. I'm at work. I was out in the, during the surgical recovery, but I've been back in without limitation. My life is much as it was before that. And I just feel, obviously, that's not everybody's story, but I feel very lucky that it is mine.
It's wonderful. Thank you so much. Thank you to Mr. Curry, to the entire panel. And we'll take a short break, just maybe 15 to 20 minutes for coffee, and also to have a chance for everyone to get to talk to each other. Thank you so much. Okay, welcome back from the break, everyone. We're, I think, going to get started again with our next session. And so for the next part, we're going to have 3 talks. We're going to have Dr. Hurwitz and Dr. Schoenfeld talk about kind of where we are right now with current medicines for kidney cancer. I'm going to talk a little bit about what's in the pipeline, what's to come, what's the science, and what are the clinical trials, including ones we have here at Yale. And then we heard a lot about this emerging role of radiation in kidney cancer. And we're lucky to have Dr. on here today with us, really an expert in kidney cancer radiation. And then similarly, we're going to do a panel afterwards, including one of our patients, for you to be able to ask any questions you might have. So I'm excited for this next session. And to kick us off, we have Dr. Schoenfeld and Dr. Hurwitz, a phenomenal tag team of medical oncologists really at the forefront of kidney cancer therapy. So thank you so much.
Howdy, everybody. Okay, so I'm Mike Hurwitz, even though David is the first speaker. David's actually going to talk about the treatment. I'm actually going to torture you by bringing you back to high school and talk to you about sort of the biology of things and not talk specifically about the medications, what we use. So I think these are really important points. Actually, David made this slide, which is a great slide because I think these are incredibly important things that seem obvious to us because we live in it, but may not be as obvious to people who don't actually live this every day. So first of all, what do we mean when we say advanced cancer? When we are talking about advanced cancer, it's something that has really progressed outside of the primary, which in this case is the kidney, and it's spread to some other part of the body. And that's exactly the same thing as stage 4 disease or metastatic cancer. People always ask, well, what stage is my stage? Anything that has spread outside of the original organ is stage. And then another big area of confusion is that even if you have it spread elsewhere, it doesn't make it a disease of that other organ. If you have a kidney cancer that's spread to the lung, it's still a kidney cancer. It's going to behave like a kidney cancer, but it'll be somewhere else. It is not lung cancer. Kidney cancer to bone is not bone cancer. It's kidney cancer that is somewhere in the bone. And then, what we're going to talk about is that we're going to talk about systemic therapy in this talk. That's what David's going to talk about. Now, I, on the other hand, actually, one more slide before I get into my stuff, which is that the way we treat now is wildly different from the way we used to treat. Harriet spoke about that a little bit ago, that we started with these things like interleukins and these other drugs way back when. And then there were these blue ones that really changed the way we think about it. And then there are these green ones that we really changed, that really changed the way we think about it. And I'm going to start by talking about the greens. So we're going to talk about the immune system. So now we're back in high school. All right. So we're going to talk about immunology a little bit. And, the immune system is this huge organ in the body made up of cells that circulate around. It's also, the skin is considered an immune organ. And really the goal of the immune system is to protect you from things that are foreign. And in order to do that, the immune system has to know what isn't foreign. They have to know what's self. And the way that our cells tell the immune system that we're self is that they are constantly recycling their own garbage and putting it on the surface of the cell and saying, this looks like me, okay? And I've drawn that this way. Oops, sorry. I've drawn that this way by showing this is supposed to be a protein. We chop it up and we literally put it on our surface. And T cells know that, oh, this is us, and they don't do anything with it, okay? On the other hand, when you get an infection, something foreign, what happens is that same foreign thing, in this case, a bacteria, which I made, which I thought was actually kind of cute. Anyway, its proteins get chopped up, it gets stuck on the surface, and the T cell recognizes it, and then you would think, oh, well, then the T cell will destroy it. But that is actually not what happens, okay? Something else has to happen before that to occur. And what happens with that is there has to be another thing that the cell says, I'm sick. There's something wrong with me, okay? And that is a signal they send out that they stick on their surface, and it's recognized by the T cell, and that says, oh, this is a sick cell. So if you see something foreign in a sick cell, we should destroy that cell and destroy whatever's in it. And that we call co-stimulation. And it's important because it's in really big, bold letters. This is like 48 font, okay? All right. And so the T cell gets activated by this, and then really big stuff happens, and that's in green. Okay, and it kills the cell. Great. Okay, what does that have to do with cancer? Is cancer foreign? Cancer is not foreign. Cancer comes from us, right? Sorry, but before I get there, let me say one last thing, which is that this is all well and good, but you certainly don't want this to go on forever, right? You don't want T cells activated and destroying things because they'll do it willy-nilly. And so T cells have ways of turning themselves off, okay? And the way it's done actually is that thing, that co-stimulation thing where we had a thing that recognized it in the T cell, they start making something different that actually turns it off called CTLA4. CTLA4, don't forget about it. That one's important, okay? There's another system we have that also turns things off called the PD-L1, PD-1 system. And there are all these drugs for that if you watch old person TV, which I do, you'll see ads for it all the time for these drugs, like Keytruda or Opdivo or things like that, okay? All right, so what does that have to do with cancer? Well, what it has to do with cancer is that cancers inherently are mutated. And that means that the blueprint that makes cancer cells, the DNA, has errors in it. And when they have errors in it, the blueprint codes for proteins that are misshapen. They look foreign, okay? And that's what makes them look foreign. And the immune system recognizes these things as foreign. And I drew them like with the purple and the yellow to make it look foreign because they're mutated. And thus, it's recognized by the T cells as abnormal, okay? However, cancer cells use the fact that T cells will turn themselves off to block the immune system from killing them, okay? But maybe if we could just block this interaction or the PD-1, BDL1 interaction, the T cells will get turned on again, okay? And that is one of the main treatments that we have, which David will talk about. And there are all these antibodies that we built that will block the interaction between these two things and these two things. And these are the drugs that have become really the mainstays of treatment, okay? I'm gonna talk about one other thing and then David will get up here. And this one is also equally complicated, maybe more so. All right, just to hurt your brains. So it has to do with the fact that kidney cancers are very vascular tumors. And what actually makes blood vessels grow is a key part of what makes kidney cancers grow. And the things that make blood vessels grow in the body are having a lack of oxygen. Makes sense, right? If your tissue doesn't have oxygen, what do you want to do? You want to get oxygen there. How do you get oxygen there? You make blood vessels, okay? And we do it through this oxygen sensing system. And there are all these important proteins. There's something called HIF, all right? HIF alpha. And when there's oxygen there, all right? So when there is oxygen, you don't want to make blood vessels, right? You don't need it. You have the blood vessels already. So when there's oxygen there, the oxygen actually ends up binding to the HIF in a certain way. And there's a protein called VHL, also important in kidney cancer, and it actually breaks it down. So HIF doesn't do anything. It just gets destroyed. It doesn't need to do anything. You got blood vessels. What happens if you don't have oxygen? Well, if you don't have oxygen, then HIF doesn't get modified. It isn't recognized by VHL. You make lots of it, and then it goes into a different part of the cell, and it makes all these products that make blood vessels. And the big thing that makes blood vessels is a thing called VEGF. And VEGF turns on something called the VEGF receptor, and that makes new blood vessels. Okay. Turns out that some people have a VHL that never works. And if the VHL never works, it doesn't matter if there's oxygen there or not. You're always going to be making all these things. And people with the VHL, it's called a syndrome, von Hippel-Lindau syndrome, they get, amongst other things, kidney cancers. And that's one of the ways we figured out that this whole pathway was so important, okay? But what's also important is that we can block this whole process. And by blocking the process, that is the other main way that we treat kidney cancers, okay? And there are all these drugs that we use. There's a new one called belzutifan. There are all these. And David is going to take it away from here, all right?
All right. Well, thank you, Mike. Now that we've all gone back to high school biology class, let's get into some of the nitty gritty of the actual treatments that we use. So I'm going to go through a few different therapies that Mike touched upon in reviewing the mechanisms. And this is just a general top line overview, just some take home points really for these regimens. Not really all the details of the studies. There's been a lot of studies on these drugs. We have a lot of data. We're happy to talk about it, but I just wanted to do some general overviews. And many of you or your family members probably been on or been at least talked about some of these therapies if you have advanced kidney cancer, advanced RCC. So the first one I wanted to talk about is a combination of these what are called immune checkpoint inhibitors. So these newer forms of immunotherapy that take the brake off the immune system that Mike had talked about. And specifically, I'll talk about a regimen that we use a lot a combination of an anti-CTLA-4 agent, so like Mike said would be very important, called ipilimumab, and another one that targets the PD-1 system called nivolumab. And so we often refer to these drugs as ipi-nivo, so you might hear me using that term for the rest of the talk, and their branded names are Yervoy plus Opdivo, so you might be more familiar with those names as well. So just some basic logistics. These are IV therapies, so these are drugs that you get by IV. You don't need a port, they can go through your regular vein. You get the 2 drugs every 3 weeks, and you do that 4 times. That's the way these regimens were studied, and that's a way to best balance efficacy and side effects, we think. And then you only get the 1 drug, the nivolumab or the Opdivo, and you generally get that every 4 weeks after that. So some basic efficacy data. So we now have really long-term follow-up for these drugs. We've used them for a while in the clinic, not only for kidney cancer, but for some other diseases as well. But for kidney cancer now, we have 9-year follow-up data for this combination of drugs. And the response rates, and when I say response rates, that means how much do these drugs actually shrink the tumors, which is sometimes if we just stabilize the tumors, that's also what, a good outcome. But how often do they actually shrink the tumors? So we think it's in the 40 to 45% range. These drugs, I think it's key to know, it takes a little while to rev up the immune system for most patients. So they don't have a quick onset of action, but one of the real benefits of them is that they have a long duration of response. So if you're shrinking your tumors or have good tumor control with these drugs, you have a chance of having prolonged tumor control. And there may even be a subset of patients who have really prolonged responses going out many, many years. And we've really seen that borne out in the longer term data. And there is even a possibility for patients to get these drugs to go off treatment and just be observed. Now, that's not going to be everybody, but for a subset of patients, you can get treated, things look controlled, and there'll be a chance to go off and just be observed. And we know that that could be a safe option for some patients. Now, we talked about the efficacy, but it's one thing we always want to balance are the side effects. So what are some of the side effects we see with these drugs? So it's very unique. These aren't like your traditional chemotherapies. They activate the immune system. And because of that, some of the side effects we see are autoimmune-like. So that's really what we look out for. And that can really happen in any part of the body, but there are some more common ones that I talk about, and I'm sure we all talk about with our patients when we're talking about these drugs. So fatigue is probably the most common, rash or itchy skin, pruritus, joint aches or arthralgias, diarrhea or inflammation in the GI tract is a big one. And then effects on the endocrine system, most commonly hypothyroidism, where your thyroid function goes away. And so some of these are temporary, some of them go away on their own, some of them we have to give medications for. And when we do, we give immune suppressive medications like steroids or some other things sometimes. But I think it is key to know, and we always counsel our patients, that some of the side effects can be long lasting. Some of them can be more minor and things that we can take care of, basically. So give a thyroid replacement hormone for hypothyroidism, but some can be long-lasting and severe or even life-threatening, such as adrenal insufficiency is a little more serious. And then certainly if you develop type 1 diabetes or even inflammation in the heart called myocarditis. So these are drugs, so they're very effective drugs, but they really do have some serious side effects that go along with them. All right, to switch gears now and talk about a class of drugs called tyrosine kinase inhibitors. So these are something that Mike touched upon that target some of the key pathways that power the kidney cancer cells to grow by turning on the VEGF pathway. And so some of the drugs we use to inhibit these pathways are shown here. So some of the common drugs we use, such as cabozantinib or lenvatinib or axitinib are listed. There are other ones that we will use and some of the older forms that we don't as commonly use anymore. So these are pills that you take. So a little different, not IV therapies. You generally take them once or twice a day. Most of these you're taking every day. Sometimes though, because of side effects or just we want to increase the chances that people can take them, we do modify them. You might not take them every day after some time. And so I think what's key to know about these drugs is they have a quicker onset of action generally. So they're a little quick on, but the duration of response is generally not thought to be as long. So most of the time, resistance develops in a person's cancer after some amount of time. Sometimes it's a little longer, but most of the time we don't expect to have prolonged responses with these sorts of drugs. And just know if you've been on a lot of therapies, the efficacy, so the activity of these drugs goes down a little bit, we expect. And I'll talk about it a little bit in the next slide. Sometimes they're used in combination with not only immunotherapy, but other classes of drugs as well. And I won't touch upon some of that during this talk. So what are some of the side effects we see with these drugs? So it's different than the immunotherapy drugs, or at least a different mechanism how they come about. And that does have meaning because generally means if we stop the drugs, the side effects do tend to go away. Oftentimes we'll try to help people and give them supportive medications. So some of the common things we see are GI side effects. So if you're having nausea, we can use anti-nausea meds. If you're having diarrhea, we can use anti-diarrhea meds. But generally, if those aren't enough, we can hold the drugs and people tend to start feeling better. Sometimes a little quicker, sometimes it does take a little longer. Some of the other side effects we see that are a little unique to this class of drugs, in addition to the GI side effects and fatigue, are what's called hand-foot skin reactions, or a reaction on your palms or your hands or your feet, where you can get blistering or sensitivity or swelling. You can also get some mouth changes, some ulceration, some sensitivity there. That can be really meaningful. We also see increased blood pressure, so hypertension is a common thing seen with these drugs, and then some other things like impaired wound healing, which may have implications if a patient needs to go for a surgery, and then also protein in the urine that we look out for. That generally comes with more time. But like I said, we can give these drugs now in combination. And these can be really useful in certain situations where we give one immunotherapy drug. Generally, it's an anti-PD-1 agent, so one of the checkpoint drugs, and we combine it with a TKI. And the most common ones we use are listed here, where the first drug is an anti-PD-1, so we have nivolumab or pembrolizumab, and we give them with one of the combinations with a TKI. So because it's one of each, we give one of them is the IV therapy, that's the immunotherapy, and the other drug is the pill you take. So you're getting a little bit of both. And the expectation is you'll stay on the pill therapy for as long as we think it's working and is tolerable. The thing to know about this class of medications is they do have high initial response rates. So generally higher than just the combination of the two immune therapy drugs. So response rates in the 50 to 60% range, sometimes a little higher. Generally, we expect most patients' tumors to respond. So it'll be low rates of what we call primary progression of someone's tumor starting to grow right away. And they're a little quicker because they have that TKI combination with them, that pill you take. But I think what we've seen as some of the longer term studies have come out is that these drugs the responses don't tend to last as long, certainly compared to Ipi/Nivo. So that is one thing we were hoping wouldn't be the case, but I think increasingly has been borne out by the data that the duration of response is not generally as long as the combination of two immune therapy drugs. And so a corollary is that there's fewer longer term responses generally. And the side effects of these drugs generally overlap with each different class. So there's the autoimmune side effects, although the frequency of these side effects is lower because you're not getting two heavy-duty immunotherapies, you're just getting one. So you can have all the same sorts of side effects, just at a lower frequency. And then you have all the typical side effects that go along with the tyrosine kinase inhibitors. And sometimes if we're not sure which one, or we think one drug is causing a side effect and the other one's not, we might hold one or the other. And then the last slide, I wanted to talk about the last class of drug, or the newer drugs that Mike had mentioned, the HIF-2 alpha inhibitor. So again, hitting another key pathway we think is driving the kidney cancers. So the approved drug right now is called belzutifan or Welireg. There's some other drugs being studied currently. So again, these are pills you take every day. They've really been studied so far, have the most data for using it really in the later line setting. So after patients have received many therapies. And we think in this setting, they do seem better than the older therapies that were available with response rates, like I show, in the 20-25% range, but much better than previously existing therapies. And they may have even higher activity rates if you use them earlier on or with certain combinations that's being studied right now. And they do have some unique side effects as well. You can get one of the really unique ones that we see probably most often with it is anemia. And that's just the way these drugs works. We're trying to turn off the production of red blood cells and blood vessels. So it is kind of what we expect, and then we have come up with ways to deal with it and try to get around it, in addition to sometimes holding the pills or reducing the dose. But we know we can give blood transfusions or even give agents that stimulate red blood cell production. Those can be helpful. And then another unique side effect to this class of agents is hypoxia or low oxygen. Again, something that if you look at the biology might be expected from this class of drugs. And fortunately, that's a little less common, but sometimes patients do need to go on extra oxygen to help get them through either temporarily or before a dose reduction happens. So my last slide, I think one key question that emerges, that emerges from all these different types of therapy is what do we start with? Like, how do we choose the first therapy to start with someone who has developed advanced kidney cancer? And this is a really key question, of course. And I just echoing some of the other talks that we've heard, it really is personalized for each patient. So it really is a discussion with your oncologist. What is the best therapy? And it depends on your individual factors as a patient, your medical history, and some of your tumor characteristics all play into it. But just trying to give a window into how we think about it, generally, if a patient can get immunotherapy now, and there's some exceptions, I'll talk about that with the last bullet point, our general preference is to try to give the combination of dual immunotherapies, the ipi-nivo, just because of some of the factors I talked about, that we do think now, and we have the data to kind of support this, that it does give the highest chance of having a prolonged response. And we really want that for our patients. We want them to have, these prolonged deep responses, and ipi-nivo, we think, can give that. But there are certain exceptions and times we wouldn't want to do that. So first, if someone isn't a candidate to get immunotherapy in general, or we think the side effects from 2 immunotherapy drugs might be too much, and then we wouldn't want to consider that. But also, because they do take a little longer to come on, if a patient needs a more immediate response, they're in a lot of pain, they're having a lot of symptoms, or we're really worried about a particular organ system getting into trouble if the tumors grow anymore, then we want to make sure we're getting a response. Then we might alter and give, for example, let's say the combination of a PD-1 plus the pill, the tyrosine kinase inhibitor, because we know it has high initial response rates and works a little faster. And then there is a subset of patients who can't get immunotherapy. And that most commonly we see for people who've had an organ transplant in the past and who are on immune suppressive drugs, or have a history of really severe or really active autoimmune diseases where we know giving an immune checkpoint inhibitor might really activate those autoimmune conditions and really lead to either a lot of morbidity or even put a patient's life at risk. So then we maybe not consider the immunotherapy drugs and want to go with one of the oral drugs that works a little differently, like a tyrosine kinase inhibitor. And so that will wrap it up. So I just want to say thank you, and we'll take questions during the panel. So.
Thank you so much. That was a phenomenal overview of kind of where we are today in kidney cancer. And so I'm going to talk a little bit about hopefully where we're going to go in terms of systemic therapy, in terms of medicines for kidney cancer, and how we get there, the path to tomorrow. And so as a starting point, where are we today in 2026? So this is a busy slide, but I think it highlights what we've heard a lot about today. We've made tremendous progress over the last 20, 30 years in terms of the number of drugs that are available, in terms of their activity. And there's still more that's sort of in the pipeline to come. So this is incredible. People are living so far, far longer, even with advanced kidney cancer, than they ever did before. And there are some people that are really going into remission with these modern therapies. But we also know that we have to face reality that in 2026, most people with advanced kidney cancer still will not go into remission. And that means we have to do better. And so where should we go? What should be kind of our North Star, our guiding light in terms of how we kind of push this forward? And I think I'm so lucky to have Dina here today. This is really, I think, a fundamental thing that really the field hadn't done before, which is ask patients where we should go. That should really be the guiding light of like where we should go with our research and our treatment. And Dina did just that. She presented at our big cancer meeting, our 40,000 person cancer meeting in 2023, which is to ask patients with kidney cancer, what is most important to you? And we can see that the top things that are most important is basically people want to go into remission. They want long-lasting, complete control of their cancer. And while we're there for some patients today, we're not there for the majority. And so the way to get there really is through clinical trials. We really have to go from that being a small minority of patients who get into remission to the most common thing that we see. And so I want to give just a few slides just because we work in the world of clinical trials a lot, but it's not obvious to everyone what a clinical trial is. Simply put, a clinical trial is a research study done in people. It's something that's done to learn. There's things that people have done clinical trials for hundreds, even thousands of years. Back in the days of scurvy, people did clinical trials to see which vegetable or fruit would help treat people's scurvy. So these are things to really study in people. It helps us learn what is safe, what works, and who it's best for. There's lots of different types of clinical trials. Phase 1, phase 2, phase 3, you sort of might see these terms thrown around. So I want to give just a very brief idea of what these things are. When we do a phase 1 trial, that's often the first time we're studying those drugs in people, or at least that drug in combination or in this disease. So it really is early. And really what we want to figure out is this drug safe to give? And what is the right dose for people? We hope it's effective, but it's really at the earliest stage of what we do. If something kind of passes muster there, then we move it on to phase 2. And phase 2 is a larger study that helps us to understand, does this really look like it has activity? Does it look like it has a good effect? And if it does, then it moves on to these big phase 3 trials. These are often hundreds or even thousands of people, and these are often randomized, meaning people are getting either the new treatment or an existing standard treatment, and it's really meant to answer the question, is this new treatment better than the old one? And so these are the typical phases of a trial. What kind of setting might a trial be performed? Really, there are trials that might be applicable to almost anyone with kidney cancer. And what we've really done over the past number of years at Yale is expand the number of trials we have so that many people walking into the door at Yale will have an opportunity to participate in a clinical trial. That might be for some patients even before surgery that wasn't really done in the past. And now we're starting trials even in the space for specific people before surgery, after someone has had surgery to try to decrease the chance of it coming back. If people have more advanced kidney cancer, trials for the first type of drug or treatment they might get. And for people who have been on 1 or 2 drugs already, or even more, clinical trials for new types of treatment. So we really have tried to expand this across the board. So if we look at where we are today at Yale in terms of the number of clinical trials we have for kidney cancer, we have actually very, very large number, and it's growing. We have just about a dozen different clinical trials that we offer at Yale. And again, we really tried to build this in a conscious way so that people coming in, whether it's for certain people with localized disease, meaning cancer that hasn't spread before surgery, after surgery, the first type of treatment that they see, the second type of treatment, there's opportunities for lots and lots of people. So how do we go from this, which is a mush of words and different acronyms, to actually understanding what these drugs do and basically what is the new forefront of treatment? And so you've heard today a lot of our focus at Yale has really been on immune therapies. That's not all we do. We give a lot of targeted therapies and we study targeted therapies. But again, if we look throughout the history of kidney cancer back to 20 years ago, that high dose interleukin-2 era, to where we are today with immune checkpoint inhibitors, it's immune therapies that have the biggest chance to have people not just live longer, but really, in some cases, go into remission and really live for the rest of their life with control of their disease. And so how do we think about immune therapies? I think Mike gave a very good explanation. I have a much dumber explanation, but this helps me to sort of think about it, which is you have a car full of immune cells and you're trying to drive it as quickly and as accurately towards the cancer as possible so that a car full of immune cells can do their thing and attack the tumor. So how do we get it there as quickly and as accurately as possible? Where there's kind of 4 big buckets. One is we can take our foot off the brakes, and that's what Mike had talked about, that idea of immune checkpoint inhibitors. Ones we have today, but we're going to talk about some new ones as well. We could really press on the gas pedal. That's actually what that high-dose interleukin-2 had done 20 years ago, but there's new ways of engineering these types of molecules to really press on the gas pedal in a more effective way. None of those things tell the car where to go, right? They make the car go faster, but they don't actually tell it to attack the tumor specifically. And so through things like cell therapies, through T-cell engagers, through vaccine-based approaches, another strategy is to try to really steer the immune system towards the cancer to try to attack it. And then very briefly, I'll talk about you can do all of these things, but if you're stuck in traffic, you're not going to get very far. So sometimes there's traffic in the way and you have to clear out the traffic in order to get there. There's a lot of other things that might block the immune system from working well. So what I'm going to do is very briefly just touch on each of these and some of the clinical trials that we're doing and have done in these different spaces to really try to push immune therapy forward for patients. So starting with releasing the brakes, this is the most common standard immunotherapy a patient would get today, the things that we heard about like Nivo and Ipi, but we're really exploring new types of immune therapy as well. Dr. Schoenfeld is leading a trial here at Yale, which is going to open soon, which is basically building on traditional therapies, but putting together in a very nice way. So he had talked about the idea of using a targeted therapy that targets this VEGF pathway and immunotherapy. What if we put them together in a single molecule and see if that works better? It turns out in lung cancer, this works quite well. There's I think a quote from Picasso, which maybe never happened, but said, something along the lines of, smart people invent, brilliant people steal. So this is us stealing from lung cancer. They have had this wonderful experience where they've done things like combine an immune therapy and a targeted therapy individually, didn't work so well, but putting it together in this one molecule seemed to work a lot better. And so there's a new study, the Rosetta study, that's coming out that Dr. Schoenfeld is going to lead, opening hopefully later this year. This is for people with the first type of treatment they receive. It's going to be given in various combinations to see if that improves things. So that's building on a history of success. But there's also new targets that we're working on. So we had led a study out of Yale that was a multi-institutional study, basically targeting a break that's within the immune cells themselves called HPK1. We actually saw, this was a first in human study. This had never been done before, but each of those red lines is an individual patient. Going along, that's how long they were on treatment for, and that's the degree of tumor shrinkage. And again, it's not for everyone, but these are patients who have received a lot of prior treatments, and we see that there are patients who had their tumor shrink for quite a while, and some patients had their disease controlled for quite a long time, for years. And so this idea of inhibiting this molecule HPK1 is something that we're pursuing. We're opening new trials, hopefully later this year, to really target this molecule. There's another break called PTPN2. This is another one of those breaks within the T cells that basically, this one is clever because it works in two ways. It actually tells your immune system to turn on more, so that's a great thing, but it actually makes the cancer cells themselves more sensitive to being killed. And so there's a new drug. It doesn't have a designation as ABBV CLS484, but that's a trial that we just opened, and there's been some not unpublished but encouraging early signs of this drug's activity specifically within kidney cancer and particularly clear cell kidney cancer. So that's a trial we actually have open right now at Yale. So moving on from releasing the brakes, the next thing is really trying to press on the gas pedal. Again, this builds on the success of high-dose interleukin-2 from years ago. And this is just putting into a graph what Harriet had mentioned earlier, which is these are patients treated with high-dose IL-2 years and years ago. There are patients who unfortunately did not respond. That's the bottom curve. There's patients who had a partial response. And then there were a certain number of patients, 5 to 10%, that had a complete response. And if we looked at how long they were living, that is measured in years. So we see decade, 15 years later, those people who had a complete response were living, again, really over a decade later. It wasn't the most common outcome. It was, again, only 5 to 10% of patients, but it kind of builds on this idea that this sort of durable remission is possible, and how can we make that more common? Again, by pressing on certain gas pedals. And so there's lots of ways that we're trying to do this. And these are just some of the trials we have open right now. One is to take that IL-2 molecule, but rather than give it everywhere in a way that we think is very toxic, to actually deliver it to where it needs to go, to the T cells specifically that we want it to work on. We had a trial along that effect earlier, and there's one being led at Yale by Dr. Hurwitz that basically has a clever engineering to bring that IL-2 molecule to exactly where it needs to go. There's a study being led by Dr. Kluger, which says, we don't have to just look at IL-2. There's many of these gas pedals we can press on. One of the ones that comes out of Yale Science actually is this IL-21. It's basically something that teaches your immune cells to kill better. So rather than just saying, let's unleash the T cells, let's actually educate them on how to kill cancer cells more effectively. And this is a molecule that basically directs this IL-21 directly to the immune system that helps it. This has just been opened here at Yale by Dr. Kluger. And then finally, there's another one of these cytokines called IL-18. It actually has a natural break within the body. And if we can remove that break, this anti-IL-18 BP, we can really hopefully let this work better and unleash this IL-18 that's present naturally in the body to work. And this is being led by Dr. Schoenfeld and Dr. Kluger. So lots of ways. These are all active trials that are open here at Yale that we're trying to really push on that gas pedal. Okay, the next part is, again, we can take our foot off the brakes, we can press on the gas pedal, we can make the immune system go. Can we actually teach it where to go? Can we actually add a GPS and basically tell it where to go? And there's many ways to do this. So our first attempt to do this was through a personalized cancer vaccine study. This is different than what we think of with most vaccines. We give most vaccines preventively, right? We get them in childhood and we try to prevent infection. This is really given therapeutically. And in this first study, only 9 patients, but what we did was patients who had a high risk of having their cancer come back after surgery, we made a personalized vaccine targeting those things that make the cancer unique and delivered it to patients after surgery. And basically, it's only 9 patients. So we always have to be incredibly cautious about how we interpret things. Those 9 patients fortunately did very well, but it's very early days. It's only 9 people. The early things we learned, it was safe to do this. What we tried to do, which was really steer the immune system to attack cancer and to attack those targets on the tumor cells, was successful. Each of those little dots is an individual T cell in a patient that was capable of attacking the cancer. And it's really what motivated a much larger study that we had run here at Yale, but internationally as well, together with Merck and Moderna. This was a much larger 270-person study called INTERPATH 004. It was a randomized study, so it really will test, is this really an effective strategy to prevent kidney cancer from coming back? It's actually, patients were very eager to participate, so it enrolled very quickly. The 270 patients enrolled in under a year, and now we're waiting to see over the next couple of years, is this something that really worked? Cancer vaccines is something we're really interested in, but it's not the only way to add a steering wheel. There's other ways to really direct the immune system to attack the cancer. It turns out kidney cancer does have things that are not maybe 100% unique, but pretty different on the surface of that cancer cell that distinguishes it from other cell types. And one of those things is ENPP3. It's a protein that's on the surface of those cancer cells that ends up being really, really high in clear cell kidney cancer, actually in some forms of papillary kidney cancer as well. And so there's a first molecule out called XmAb 819. It rolls off the tongue, but this is a T cell engager. It basically has 2 parts to it. One is it recognizes the cancer. The other is it recognizes your immune system, your T cell, and it literally drags T cells into the tumor and turns them on to attack. And again, this is very early days. This is a phase 1 trial, but the first public results were presented over the fall. And what we saw in patients who had received lots and lots of different types of treatments, again, each of those lines is a single patient. We saw about a quarter of patients had their cancer shrink. And some of those patients already, that shrinkage was going on for a long time, for over a year. And so this is, again, another promising way to really steer the immune system towards cancer. I'll very briefly mention the last one, which is clearing the traffic. The idea here is there's lots of things that can get in the way of an effective immune response that we might need to clear out of the way. There's too many things to list, but one of the things that people have been excited about for a while, but not really known what to do with, is maybe actually diet and the bacteria that live in our gut maybe makes a difference in terms of how our body responds. And this has been an idea that's been floating around for a while, but the folks actually at City of Hope began to test this as something that we could actually intervene with. This is a very, very, very small study. This was only 30 people, but what they did was they gave people the standard therapy, that Ipi and Nivo that David had mentioned earlier, or they gave them Ipi Nivo plus actually a live bacterial product, something that helps your gut bacteria called CBM588. This is actually something that's widely available in Japan. It's used to treat indigestion in Japan. And it turned out that the people who got that CBM588 in this very, very small study did a lot better. You have to interpret this with caution. It's only 30 people, but it sort of had this idea. Can you actually positively clear the traffic of kind of bad bacteria in the gut and put good ones in instead? And might that help? And so through a large national cooperative group called SWOG, the BioFronter S2419 trial is just being launched. It's not open yet, but it's going to open later this year, which basically is going to be a national study that randomizes people to either get the standard immunotherapies that you get anyway as the first treatment, or the immunotherapy plus this CBM588, or they have a new designation for it, to really see if this helps. And the idea here, again, is really clearing that traffic. And so I've gone through a lot of clinical trials. We've really expanded our clinical trial portfolio, what we have to offer at Yale. There's always the question, okay, is a clinical trial actually right for me? And that's really a personal, I think the theme you'll hear today over and over again is everything has to be personalized. There's no one size fits all. And so I think there's advantages of clinical trials. Obviously, I'm excited about it. It provides really access to the cutting edge approaches in cancer therapies and in kidney cancer specifically. And I think it also helps us to learn. There's a benefit we hope for the individual, but there's also a larger benefit of understanding the science and biology and whether these medicines work. But there are always risks with these things. There's the effectiveness of these therapies are often unknown. That's why they're being studied. The side effects might not be perfectly known. So there's certainly risks that come with it. It might be more of a commitment. It might be coming in more frequently for visits. It might get extra samples, extra biopsies or blood draws. And then there's anyone who's been on a clinical trial know there's this basically this mortgage paperwork looking thing of different eligibility criteria, different things that checkmark boxes that have to be filled. And so not everyone might be eligible to participate in a trial, but something that we have a growing sort of repertoire of them at Yale. So it's something to always ask your doctor about. And so with that, huge number of people to thank. I think most of all, the patients and their families are the ones that actually are going through this and making these trials possible. Many people to thank in terms of investigators, but also I just want to shout out the people behind the scenes, which are our incredible clinical research team for kidney cancer at Yale. Patty Braun, who's our clinical research manager, our clinical research nurses and coordinators, Beth, Barbara, and Chioma, who do an outstanding job. If you're on a trial, they're often the face that you see, but there's many people behind the scenes that are doing the scheduling, the data coordination, Gail, Liz, Sean, John, and then many others that get these trials open and make sure they're compliant from a regulatory standpoint. Melinda, Leah, many others. So I just wanted to thank them because they together with you are what makes this possible. Thank you so much. Perfect. And I'm excited to welcome Dr. On next. We heard so much about radiation, and I think radiation in kidney cancer has this historic association of not working, right? People sort of have, and this is still prevalent among a lot of medical doctors who don't see a lot of kidney cancer, that radiation doesn't work for kidney cancer. It's not sensitive to radiation. I think that's completely changed in the modern era with new techniques. And so we work with our radiation oncologists. I was telling him I probably email him every Saturday or Sunday as I prepare for clinic about one patient or another. So I'm so thankful to have Dr. On speak today.
Well, thank you so much, Dr. Braun, and really appreciate everyone's time. It is an incredible honor to have a chance to speak with you. So exactly, I'm a radiation doctor. I focused my training and expertise on radiation for cancers, particularly kidney cancers. A very different technique, very different tool than surgery or some of the really exciting whole body treatments that we've talked about today. So what is radiation? Some of the basics. Radiation can be a really scary term. People think about nuclear power plant accidents or even comic books. But really, when we use radiation in medicine to target cancers and tumors, we're just using high energy X-rays. We're doing it in a very planned and targeted way, where we're just giving very focused radiation to parts of body with tumor. And using very modern machines and techniques that we'll talk about. And so that's very different in terms of safety compared to giving radiation to the entire body or giving radiation in a very non-discriminate way. Some basics about how radiation affects cancer cells. This is important because it really differentiates radiation side effects, outcomes, how we actually follow patients after radiation treatment. The radiation actually damages the DNA, the genetic code of the cancer. But even with that damage, it doesn't necessarily induce a lot of changes right away. In fact, it's not until when the cancer cell tries to grow again, tries to divide the DNA, go from 1 to 2 cells, we think that's generally where the majority of the damage from the radiation takes place on the cancer cell, leading to either the cancer cell to die or to actually kind of hold still and not be able to grow anymore. And that's really important because when we give radiation, even we talk to the patients and we see tumors on scans, we warn them, we don't really expect the tumors to look that differently right after treatment. And it can either take a long time for us to see tumor shrink, or sometimes the baseline expectation is just that we don't want to see tumor grow anymore, okay? Because you can absolutely have inactive cancer that does not have the capacity to grow after radiation, but it's still there. So setting that expectation can be so important for patients when they see or read their scans after radiation. Notably, when the cancer cells get radiation damage, we think that it absolutely does not repair the radiation damage nearly as well as some of the non-cancer cells in the same area. So when we design radiation, we can certainly target the tumor or just the area right around the tumor. There's generally always going to be some non-cancer cells in that area. Far away from that in the body, there's really no radiation effect, but just right in that same vicinity, some of the normal cells, non-cancer cells, will get radiation damage as well. But we absolutely do take advantage of the fact that some of the normal cells can repair some of the radiation damage much, much better than cancer. So this is not a kidney cancer, this is skin cancer, but it's very visual. This is a skin cancer on the nose of a patient. The top left is before treatment. Top right is a couple months after the radiation, focused radiation. you'll see that most of the cancer has actually responded, but there may be still some abnormality in that area. A year after that, we see even further response, not really a visible cancer there anymore. But then a couple months later, we're seeing that some of the surrounding normal skin starting to lose its color or having some discoloration. Main point here is that we really do get this delayed response from both the cancer and from the normal cells nearby. And it's important to understand that as we're interpreting whether patients are doing well after radiation. Practically, when kidney cancer patients get radiation, they meet with us physicians, we talk about the risks, the benefits, pros and cons, alternative treatment options for the kidney cancer. But if we do decide on radiation, we always will have patients get a CAT scan to plan the radiation. The CAT scan is so important. We're able to really visualize the tumor in 3 dimensions. We're able to see exactly where some of the organs tissue next to the cancer that we really need to spare radiation. And then there's actually, after that CAT scan, there's actually a lot of downtime, usually about 2 weeks for modern, really complicated radiation. We design the plan, we pick the best plan, we actually test the plan on the radiation machine before the treatment starts. With modern kidney cancer radiation, fortunately, we're only looking at about 1 to 5 sessions, treatments, and these are completely outpatient. Patients come in, they're in the department for an hour, they're laying on this treatment table for 20, 30 minutes per treatment. And during the actual treatment, they're literally just laying there. There's a machine that will move around the body. But I really prepare patients to say when you get a X-ray or a CAT scan, it's really the same kind of energy, it's invisible. You don't literally in the moment feel anything. And so when the treatment's done, you kind of get off the table and you're able to go to your car and go home. And so some of the nice things about radiation, we're very obsessed. We're really focused on making sure patients are not moving in the middle of radiation, even if it's only 15, 20 minutes on the table. So beforehand, we'll actually make some of these vacuum bags and some of these saran wraps to make sure patients are comfortable, but still before the radiation starts and even in the middle of radiation. This is a video. I'm not sure if I'm able to play it here, but we actually do give patients a video before the radiation treatment just because radiation treatments can be such a mysterious phenomenon. You can't see it. People read about radiation side effects or accidents and whatnot. And so we have a video that really helps patients get a sense beforehand that, yes, it does take time and there's multiple steps and multiple visits, but at least going through the treatment, it's really completely not invasive. No IVs, nothing poking through their skin.
Each day, the radiation therapist will position you on using the marks placed on your body or positioning device created during the simulation. This ensures you are in the correct treatment position. We will use soft Velcro straps for your safety. The radiation therapist will leave the room and ask you to remain still. During this time, your radiation team is confirming your treatment plan and correct positioning using X-rays. Your therapist can see and hear you at all times. Daily treatments typically take 15 to 30 minutes, but in some cases, it may take up to an hour. The longest part of your time in the treatment room is the positioning process. Once you are in the correct treatment position, the therapist will step out of the room, the door will close, and your treatment will begin. The door must remain closed for safety during your treatments. You will hear and see the machine as it rotates around you, delivering the prescribed treatment, but you will not feel anything, similar to other types of procedures you may have had previously, such as a CAT scan or dental X-rays. While outside of the room, the radiation therapists will constantly be monitoring you through audio and video equipment. The radiation treatments you will receive will not make you radioactive at any time, and you will be safe to carry on regular daily activities unless otherwise instructed by your doctor.
So we'll stop there, but just give a sense of it's very patient-friendly, at least going through treatment in terms of quality of life being preserved and really not invasive. This is an example of a radiation plan for kidney cancer. This is actually a patient I treated recently, just 3 treatments. The tumor is in that red area. The radiation dose are those lines. The lines almost give a sense of how high the dose is. It's almost like elevation map. Closer to the tumor, the higher the dose. Farther away, the lower the dose. And you can see we really pushed hard on the radiation plan to spare the gut kidney, because the radiation does have side effects that we'll get into, and we really wanted to preserve the kidney function as much as possible. This is a patient who he actually has a very hard time walking. He's usually either bedbound or wheelchair bound. And it was really logistically, it took time, of course, but getting on the treatment table, was able to hold still. And so far, he's tolerated treatment very well. This example of the modern radiation plans, it's so complicated. We rely on computers to devise the plan. But so if this is if that green dot or green figure is a patient, you'll see that the machine is moving in a circle around the patient. And as it's moving, delivering radiation, there's all these complicated fingers that changing the shape of the radiation field, and we're altering the radiation dose as well. So we'll move on, but those are just some of the examples of really modern radiation. But as Dr. Braun mentioned, traditionally, we had thought that kidney cancers didn't respond well to radiation. They were not what we call radiosensitive, and we never really investigated or studied kidney cancer radiation very much traditionally. The other concern is that, especially when we're giving radiation near the kidney themselves, we've generally historically thought that the kidneys are very sensitive to radiation. Thought that we are very concerned that giving radiation, too much radiation to kidneys can lead to kidney dysfunction, dialysis, and whatnot. And there's some element of truth to both these myths. But what's changed with modern radiation is, one, we know that kidney cancers do not respond well to a very traditional, historic, low doses of radiation over many sessions. So a lot of cancers, even now, the standard radiation schedules, it's 5 days a week for 5 weeks, 7 weeks, 9 weeks even. There, we're using low doses per session slowly to allow the cancer to get more and more damage from radiation, but have some of the non-cancer cells repair itself between treatments. We now know, though, with great certainty, that with kidney cancers, we really need to hit it hard in just a couple sessions, 1 session to 3 sessions, up no more than 5 sessions. And with that daily dose being sometimes as much as 10 or 20 times compared to the traditional daily dose. The other concern with the kidney side effects of radiation is that really old radiation fields, we use really large fields, we use X-rays to draw these kind of square blocks. We would just kind of blast the organs with radiation. And if you do that to the entire kidney over a long period of time, absolutely. We're worried about not just dialysis, but life-threatening high blood pressure, other kind of issues that happens with kidney dysfunction. However, with modern radiation, we can be so pinpoint with radiation that we can knock out kidney function to a certain area, percentage of the kidneys, but a lot of times it's almost, at least so far, looks like it's analogous to just removing function of the kidney partially, almost akin to a partial kidney removal by the surgeons. So historical radiation is like the chisel, slowly giving the treatment over many, many, many sessions. And then SBRT is this modern radiation philosophy. High doses, just a couple sessions, kind of like a sledgehammer, in just one section even, trying to really get rid of the cancer's ability to grow. So a couple questions about modern radiation. First, for curable kidney cancer, where the cancer is just in the kidney, hasn't spread, hasn't really gone outside the kidney. It's big enough though, where generally we would talk about treatment. It's grown, not usually a good candidate for just washing the cancer. The standard treatment these days is surgery, of course. The question, though, is that some of these patients, they're really not healthy, right? They're worried about, understandably, or the surgeons are worried about their ability to go through surgery, to recover from surgery. So the question is, can we use radiation as a backup option for these patients who can't get surgery? The answer unequivocally is yes. For some of these patients, radiation, SBRT can be a great option. This is an example of a kidney tumor that received radiation. On the left is the tumor with the arrow before radiation. About a year later, this is the tumor after radiation. It's shrunk quite a bit. A couple key points. The tumor has not disappeared on the CAT scan, right? So very important. The tumor does not usually go away. It very rarely goes away. In fact, a lot of times the tumors don't even shrink. And we, like we said, we have to caution patients ahead of time what the expectations are with the radiation. However, this is a trial that collected a lot of patients where they receive radiation for the tumors, where the tumors just in the kidneys. After about 3-4 years, they hadn't seen any patients actually have their tumor grow larger. By really standard criteria right now, we would say a failure would be tumors growing above, say, 20% or so. So that 20% gives us a built-in buffer if their tumors sometimes swell a little bit or have some inflammation after radiation. It can be very tricky. A nuanced point is that when they've done some biopsies for these patients after radiation, sometimes they'll still see active cancer, they'll still see cancer. There's still cancer cells that's there, but it appears that these cancer cells aren't always very active. But of course, radiation is still a neuromodality with kidney tumors, and we're still learning beyond 3 or 5 years how the cancer responds, how some of the side effects are. Another question with modern radiation, when some of these tumors unfortunately spread to some of these large veins in the body, as the surgeons mentioned earlier today, one of the options, really, I would say the standard, if this is the only site aside from the kidney, is to have a really a big surgery to try to remove the tumor inside the blood vessel. There are certainly big surgeries, and same idea, right? Some patients were really worried how they will tolerate the surgery. Can we use radiation for patients who can't safely get surgery when the tumor is actually in the big blood vessel? And the short answer is very limited number of patients that have been tried with this approach, but so far there has been really promising results. This is probably just an example, the best example possible, where on the left there's actually, it's hard to see, there's a tumor in that blood vessel right beneath the kidney. About 3 or 4 months later, we see that the tumor is gone, or it's really shrunk. People have used this when the tumor is clogging the blood vessel, is causing swelling, other symptoms. That's a major blood vessel that allows for blood to return from the lower part of the body. And people have seen that with radiation, more than 50, 70% of patients, the symptoms can certainly get better, even if the tumor doesn't completely go away. Okay, another question now. Different scenario when we have patients with incurable, so kidney cancers that's throughout the body. Can we sometimes use radiation only and no other treatments to try to either either stop the cancer or at least delay the time in which the patients start whole body treatments? So for some of these early studies that have used patients where they have, and this is the key, have a limited number of cancer spots at the time of diagnosis. Generally, we're talking about 5 or fewer cancer spots. We have seen that there is absolutely a subset of patients in this study, after 3 years, a little bit under half of the patients did not need to start any whole body treatments. So again, these are very well-selected patients, and kidney cancer, each patient will have sometimes a very different kidney cancer compared to another patient. But we know that there's probably a subset of these kidney cancer patients where their cancer is either relatively slow growing, or there's not a lot of other active cancer cells aside from what we see up front on the scans. Finally, can we combine radiation, SBRT, with other whole body treatments to really enhance the effects of those treatments? And certainly, one of the key ideas here is that when patients with incurable stage 4 kidney cancers start whole body treatments, eventually what we see almost invariably is that the cancer is able to grow despite those treatments. And so logically, we have to do something differently to still control the cancer. One idea, though, is to, instead of switching to a new agent, is to try radiation if the number of spots that's growing is relatively limited. So we call that oligoprogression, this concept where we're seeing cancer grow despite a whole body treatment that otherwise has worked well, but it's not that many spots in the body based on the scans. So can we actually just target those spots that are growing with radiation, allow maybe the patient to stay on the same regimen a little bit longer and hopefully extend their whole cancer course? And we do have a trial opened here at Yale. I think Dr. Braun had included this in his slide. The PI is my colleague, Dr. Kimberly Johan. These are kidney cancer patients. They've been on immune treatment, immune therapy. And if they have any progression, but it's a limited number of sites, 5 or fewer, we give SBRT radiation to all the sites, and we see how they do afterwards. And the key here is we're continuing these patients on the immune agents. Finally, another technical, really exciting question is we have relatively even more modern radiation techniques than conventional radiation. So proton radiation is a much more complicated way of generating radiation treatment. Rather than using essentially light energy, we're using charged particles, protons. These absolutely can have benefits in that we can reduce the radiation dose to other parts of the body at the same level of treatment. So you can see on the left is more typical radiation for kidneys. On the right would be a photon radiation plan, where we're seeing less of that kind of blue and green area to the other parts of the body. This is something that's actually being studied around the country right now. We're still not certain if that better looking plan with the protons is actually leads to better outcomes with side effects, leads to better tumor control. We are very motivated to consider with protons, can we even escalate the radiation dose further? A lot of the times with our radiation dosing, we're limited by some of the organs, the tissues, normal cells nearby that just can't take too much radiation. And excitingly, we'll have a proton center available here in Connecticut. It should be later in the year. And these are questions we'll continue to ask. Side effects of kidney cancer radiation. Generally, it all depends on where in the body we are treating. If we're treating the kidneys, some patients may feel mild fatigue for a couple of weeks. Nothing really limiting, no really limitations. They can sometimes feel a little bit of nausea right around treatment, especially if there's some intestines or stomach close by. A lot of times for those patients, we'll just give them prophylactically nausea medication, and that's usually very easily well controlled. For bones, if we're treating cancer in the bones, there can be a little bit of inflammation in the bone causing some temporary pain, but usually pretty easy to control. Longer term, because again, the radiation effects continue, can certainly continue to manifest even months or years later. We look at kidney function to make sure that the kidney function is still sufficient, that patients don't need to go on, say, dialysis and whatnot. We might want to make sure some of the non-cancer nearby that receive high-dose radiation, that things are still going well. There's no bone fracture if we're treating next to, say, a rib, making sure the bowels are working well. There's no blockage or issues that can happen rarely, but not impossibly. So with that, I think key takeaways is that modern radiation is so different than traditional paradigms. And I think that things have changed so much even in the last 5-10 years with kidney cancer radiation. We're using higher doses. We're using a different scheduling. We're using modern machines. And we're having increasing evidence that in really select cases, radiation can't be a great option, whether it's patients who can't have surgery, or it's patients where we're experimenting, can we actually use it instead of whole body treatments or a new whole body treatment? It can be very well tolerated. There certainly can be side effects as with any treatments, but it can be very well tolerated. But again, the tumors don't generally disappear. They generally don't even always shrink. We're just trying to make sure that the cancer has been inactivated in the area of treatment. But again, very relatively well tolerated in terms of going through treatment at least. And so with that, thank you so much.
And with that, I know I'm staying between us and lunch, but we have just a wonderful panel. Will be maybe 15 minutes just to give a chance for folks to ask questions, and then we'll get right into lunch, I promise. So I'd like to welcome up Dr. Schoenfeld, Hurwitz, Dr. Kluger, Dr. Ahn, and then a very special guest, Ms. Gina Thomas, one of the most positive people I know, to talk about her experience on the patient front. Perfect. And this is a chance to ask questions. Oh, thank you. So, Gina, I might ask just to start off if you're comfortable sharing just a little bit about your journey and path forward, and then we'll open it up for questions.
So I am a 55-year-old Italian-American, very proud. 4 years ago was struggling with some flank pain, kind of one of those, I don't know what's going on, something's wrong. Went to my primary care, immediately got me in and was seen CT scan, and there was a large tumor in my left kidney. Met with the surgeon and my cousin who's here with me, Anita, who is, I call her my person. We all have a person, or we may have many people. She is retired APRN and has been by my side from day one and continues to love and support. So I just have to give her a shout out. I'm scared out of my mind what's going to happen. And she sat with me. And when we went to meet the surgeon, he said, "Oh, your kidney has to come out." I said, "Okay." Well, the kidney comes out, you're cancer free. I said, "Oh, okay. Is that how that works?" Perfect. So we went in, kidney came out. Months later, we found through continued testing and CT scans and MRIs, it metastasized to my lung. And I had a wonderful surgeon, Dr. Blasberg, thoracic surgeon, fantastic. Left lower lobectomy. And we had started immunotherapy, Keytruda. And, not everything works for everybody. And I understood this, but I persevered. I said, I'm going to push along and fight the fight and do what I've got to do. From there, we found through continued testing, it had metastasized to my brain. And I had 2 tumors, surgeries, gamma knife, Dr. Cheng, wonderful. I'm sorry. It's all about your team. Dr. Braun, the Dr. Cheng's, Dr. Blasberg's. It makes the biggest, hugest difference. And when you have an amazing team, it just speaks volumes. And I am lucky and blessed in that sense. So just pay attention and just know you can do this. Thank you. And I have them over at my seat because I knew I'm just a blubbering mess. And I tried. But and Dr. Braun is my constant. I met this man the first day and I looked at him and it's just, you have a feeling. And I said to him, he always has somebody waiting in the wings, somebody shadowing and training. And I looked at him, I said, can I take a picture with you, please? And he was wearing his sport coat and his bow tie and he jumped up and he unbuttoned his button and he put his arm around me and we took our first picture. So every 6 months, every year we get our picture and, he's my guy. He is like the president of Team Meatball, which is my shirt for the Closer to Free ride. Because, I'm Italian, short and round, where I was much rounder, but not so much anymore, but it's all good. So, he always has a plan. And, I struggle with a lot of the side effects. I've been on different treatments, but I just know there's always something in the back pocket. And we'll have discussions and we'll just kind of go through things and, do the best that we can together as a team. So, I'm lucky and I'm blessed and I'm able to work full time and travel. And I love going to concerts and live music and just live life. That's it. That's the best advice.
No, thank you for sharing what has been an amazing journey. And I think, when I see kind of your perseverance, but also the people around you that are helping to lift you every other day too. I'm so grateful for that. Questions? Yeah, please.
I have a quick remark and a question. As patients, we get embarked on this journey that we did not volunteer for. To be part of the team, we have this mountain to climb because most of us don't have the benefit of decades of medical training. We have to learn all these weird names and acronyms and concepts. And events like that, I think, play a crucial role in our understanding. I think one of the best coping mechanisms is to understand the disease that you're dealing with, the options, what's down the pipeline. So it gives you hope that more stuff is coming. And so thank you for organizing this because it really, I think, helps us being better member of the team. My question has to do with adjuvant treatment. It's becoming popular. It has proven to have some benefits, but it's not a cure. Some of us who have taken it or will take it will recur ultimately. And the question is, what's next? What's the thinking today if the immunotherapy basically didn't work 100% and you have recurrence? What are the options?
No, it's a a very important question. So more and more people who have a higher risk cancer that's removed by surgery, there's medicine given afterwards, adjuvant therapy like Keytruda, that helps decrease the chance of it coming back. But I wish I could say that it goes from this percent to 0 or to 1%. It helps, but its effect is modest. And so I would say two things. One is there's a lot of what we study that says, can we do better than that pembrolizumab, that Keytruda alone? That's where a lot of these cancer vaccine studies comes in, other things like Strike that we have open. The other is, what if you do that and it's still not effective? What if it's still, we see the cancer come back? And the real answer to that is we're learning as we go. These are problems that never existed prior to a few years ago. And so there's no data that says this is the exact right treatment. I think for a lot of us, and I'll have my colleagues chime in, we still think, if one immunotherapy didn't work, there's still a chance that adding a second one might be effective. There is data, not perfect data, to support that, but that's what we often try to do. And if that doesn't work, then we think about, okay, one, what are trials that are available? But two, what are some of those targeted therapies that can control the cancer, sometimes for quite a long time? I don't know if others have thoughts as well.
So actually, I'm just going to bring it back to you. So you've thought about things like monitoring people and deciding, who should get more, if it's KIN1 or something. Maybe you could talk about that a little bit.
Yeah. So one of the questions is, we go in for scans after surgery. That's our best tool right now to sort of figure out if cancer is coming back. But we know with this idea of adjuvant treatment after surgery, we're both over-treating many people, because there's many people who will be cured by surgery alone, and giving them any medicine is only giving side effects. And there's many people, unfortunately, who are being undertreated in the sense that we give that pembrolizumab and it's not enough. And so questions we have is, can we escalate for the right patient, give more therapy, and then de-escalate for the patients who don't need it? That's a hard job, because again, scans are still the best thing we have. But some of the things I was mentioning, Dr. Alam had mentioned KIM1, which is a rising marker in the blood that we're studying, many others as well. Can that be a predictive tool? There's new forms of DNA that might be circulating from the cancer that we can detect. The original tests weren't very good for kidney cancer. There's some ones that are emerging that we've been interested in. But a lot of the work is going to that sort of what we call biomarker analysis, trying to figure out who we might need to give more therapy for, who we can potentially give less therapy for.
Thanks. With everything is so new, right? So there's not a lot of long-term data on all these things. And so, Dr. Schoenfeld and Hurwitz talked about sort of maybe potentially going off of treatments. So, I've been stage 4 for almost 7 years. I've been on Nivo and IVIG for that long, Cabo for 3.5 years. I have an esoteric autoimmune disorder. There's no numbers I can look to see, like, how do I think about going off? Like, how would I even go about processing that in my head? Because I don't know where to look for information.
Yeah.
So we can all take it, because none of us have the right answer. I'll say my thing, which is that we all treat enough of this disease that we all have patients who are a little bit like you, who have unusual situations that we can't exactly fit into our studies. And to some degree, we base it on you as an experiment. It sounds terrible to say that, but that's what every single patient is, right? You're all unique. So every single patient, to some degree, we are taking what we know from looking at large numbers of patients, and then we're going to try to see how it works with you in particular. I think in your particular situation, I can't really speak to it, but from what you've said, I think that your doctor probably says, well, what do we know so far? How rapidly do we see things change in you in particular? How did you respond to treatment X, Y, or Z in particular? Where is the disease that's there right now, and what might be the complications that happen if we stop or if we start, things like that. And my guess is that your doctor is making a complicated decision based on all those factors and their experience, and saying, my guess is things are going to go this way. And with probably no quantitative way of actually saying what that is. But it's a gestalt that they get. And this is the sort of thing that we kind of BSE, we say it's the art of medicine. And the hope is that the person's experience is accurate enough to do that. That's my sort of answer. I don't know if other people have a better answer, but.
I kind of have a great problem with that. So that's the problem. Like, stable, but not stable anymore. I'm tolerating everything. How do you think about?
I just want to add that there's a difference between coming off therapy after a complete response on immunotherapy and coming off therapy after a response on the targeted therapies. And we think about that quite differently. We tend to keep going with the targeted therapies because when we stop, things tend to come back. Not in everybody, but we're more likely to keep people on.
And to add to that, we sort of believe that the immunotherapy isn't, the drugs that we give you when we give you immunotherapy isn't directly doing anything to the cancer, right? The whole idea behind immunotherapy is we're training your immune system to attack it. So our hope is that the immune system will be trained well enough to keep things under control for quite a while. Whereas, as Dr. Kluger is pointing out, those other therapies directly attack the cancer. They're on, and when they're off, they're off. So.
There was a question earlier about immunotherapy coming from that direction. I actually didn't see who was asking it, but I want to give the person the opportunity to re-ask. Yeah.
Yeah, I don't need to re-ask the question. I think it was kind of answered throughout the discussion. So I thank you.
Thank you. And as you can tell, we're immunotherapy geeks. We love talking about it.
Hi, thank you. Thank you for this. This has been a great day. I am a patient, and of course, and I am curious as to, there's such a massive amount of data, which is fabulous. But when we go through the charts, and they get fewer and fewer boxes on therapies and treatments and stuff like that, and each chart as you go along, there's fewer and fewer boxes. So my question would be is, as you go through this, there's some great stories about some people who've been doing this a long time. As you go through, and then you get to certain type of specific therapies like a chemotherapy pill, what are the options going forward I mean, I know there are options, but are there less? I mean, if you've had all of these other treatment types, and or are there more options? If I'm on Cabo now, it seems to be working, and so going forward, what would be? Is there more in the next phase, more opportunity? Because it seems to be the opportunities have seemed to be very rich up until this point.
Sure. Well, thank you for the question. And I think, it's a really good point that as you go through a lot of therapies, it might seem like there's more limited approved therapies, but I think there are still options often that are standard therapies and will always be a part of the discussion. But then we do always, if the standard therapies, or even if there are standard therapies available, we always want to consider trials, for the reasons Dr. Braun brought up, just because not only do they help us learn, but they may, we hope that they're beneficial. We have good scientific and biologic rationale usually to hope that they will be. And I think, in the current state, so many of them seem so promising that, without being able to predict the future, we think some of these will emerge and over the years, and new therapies will come. And we've seen that just over our time. I'm sure I haven't been practicing as long as some of my colleagues, but even in my time, new therapies have come on. And I'm sure over the next few years, new therapies will be approved. And if you look back at the 20 years, we've gone from, if you look at that timeline, the therapeutic way we treat kidney cancer has changed so dramatically. And I think what we've all seen is that that's accelerating. I think things are happening quicker and quicker now. So I think there will be standard therapies usually to discuss, but I think, as people go later in their therapies, always trials are a big consideration.
I think that's great. And
I'm going to say one last thing though. You asked actually an incredibly uncomfortable question, and I'm glad you did, because in the end, you're absolutely right. We run out. We have not succeeded in this disease. That's why we need to keep doing all these studies to hopefully do better. we sit there and we meet every week, actually, all of us, and talk about difficult cases and go through the 20 different combinations that we could try. We can always find something to do, but we're never happy. It's always earlier on, it's easier, and it just gets harder and harder. And the goal is either cure it. Hopefully, I would love to be able to send everybody to Pat, Muneeb, and just get rid of this stuff, or maybe these days to Yi. But otherwise, it's just finding more and more things to keep things going. But that's the answer. Your question was the answer. It gets harder.
And just my quick 2 cents is you saw a lot of those timelines today of like the development of kidney cancer drugs. And there's a lot of bubbles. And it's not to remember each one of those, but to say, okay, the number of options that have come up has exploded over the last 5 years, 10 years, 20 years. But it's also, as Mike was saying, not unlimited, right? There's still a finite number. And so that's why I sort of think, one, get as much mileage we can out of each one, really trying to maximize the use out of each one. The second is every single one of those bubbles came to be approved through a clinical trial. They all started as clinical trials. And that's why we've had such a focus on starting clinical trials and sort of this idea of Yale science really motivating it. Because one is we need to do better. We need to have more options. And the way to get there is through clinical trials.
And can I just add to that about biology? So if you look at the list of drugs that have been approved, I think it was Dr. Hurwitz outlined, or no, maybe Dr. Schoenfeld, sorry, the 3 classes of drugs that we have right now. One of those classes only has a single drug in, but there'll be another one hopefully sometime soon. And the other 2 groups have a good number in, and we can go from one to the next. But until we're able to target different biology, we're going to be struggling with the same side effects and the same issues of resistance. So that's where the money is.
Any other questions?
What's the difference between ablation and SBRT?
Great question, sir. So cryoablation is a totally different way of trying to destroy the tumor. It's actually done by our interventional radiology colleagues. That generally requires kind of direct access to the tumor with, say, some kind of device or needle equivalent to target. It's generally relatively more commonly used for kidney tumors in the kidneys when they're a little bit smaller, growing. There's different considerations between radiation and ablation in terms of who's a good candidate. With radiation, if I see maybe intestines close by, I would say radiation, I want to be cautious, maybe no radiation. With ablation, they're also looking at, for instance, the access to the tumor. Is it close to other structures that's relatively sensitive, like ureters? So there can be a lot of different considerations, but in general, they're totally different techniques. Radiation for kidney tumors, it's still relatively newer approach. The machines and the radiation dosing is very traditional for other cancers, but applying to kidney cancers is still something that we're only doing more and more of in the last 5-10 years.
So even more simply, cryoablation is sticking a needle into it and freezing it. That's what cryoablation is.
So I imagine, Ms. Thomas, that you received actually Gamma Knife, which is a special radiation machine to deliver SBRT equivalent to the brain. So in some ways, the radiation that tumor receive in the brain is no different than the SBRT for kidney tumors elsewhere in the body.
So I know it's 12:30 and you don't want to see me hangry. So we're going to pause a little bit for lunch. I just want to say afterwards, we're going to have a wonderful additional sessions on the genetics of kidney cancer, the risk for family members, nutrition, and then from our special guest, Dina Battle, on really the patient community and advocacy. But I want to thank our wonderful panel and Ms. Thomas for participating so much. Okay, everyone. Hope you had a chance to talk to each other during lunch and kind of meet this community a little bit. But we're excited for our afternoon session. We have a great lineup of speakers, and then we finish off with a panel, and then promise to get you out of here by round two. And so our next session really, I think, focuses on a lot of what sort of people think about that, especially when we're in the clinic as medical oncologists, as other doctors, we don't always have the best information on, which is things like, how might this affect my family? What are genetic risks of kidney cancer? What is the role of nutrition, and what does that play in cancer? And we're very lucky to have some Oprah-style grab bags, swag bags available that have been brought in, which we're really appreciative of. And then finally, our outside speaker speaking a little bit about the community and how to get involved with advocacy. And so with that, we'll start off with Dr. Veda Giri, who's going to speak to us a little bit about the genetics of kidney cancer. Thank you so much for joining us.
Thank you so much. It's a really wonderful event, and so happy to be a part of this. And I think this is a really nice topic to think about, how it complements the information that you received this morning from the various talks, and then what you're going to hear after this. So I think it's just a beautiful flow for the agenda. So again, thank you for having me. So I'm going to talk about this question of, can kidney cancer be inherited? Understanding the genetic risks in renal cell cancer or kidney cancer. My background is as a medical oncologist. I specialize in cancer genetics, in clinical cancer genetics. So we see patients, wanted to introduce our cancer genetics program to you all at Yale Cancer Center and Smilow Cancer Hospital. The cancer genetics program has just terrific physicians and genetic counselors that work together, great genetic counselors, advanced practice providers, and we have a novel fast track program where we have genetics coordinators seeing patients in a more of a rapid fashion who need genetic testing, since our indications for genetic testing have really expanded over the last few years. So lots and lots of patients need to think about genetic testing for themselves. And this is hereditary cancer genetic testing when I'm talking about this field and this work. We see patients across the state of Connecticut in multiple care centers as well. So we have an opportunity to really interact with patients from diverse regional areas of Connecticut into Rhode Island as well. Diverse racial ethnic backgrounds, socio-demographic backgrounds. So we really have an opportunity to think about the needs of our patients, their families, when we think about this field of genetics and genetic testing. So as we see our patients and think about what are their needs, what are the common questions that we get asked from our patients, I thought I'd focus today on three of the most common questions that we are asked when we're thinking about this in the context of kidney cancer. So the first question is, can kidney cancer be inherited? Very, very common question that we get asked by patients, by providers, by the communities. Is there genetic testing for kidney cancer? And we'll talk about that a little bit as well. And then, should I be screened for kidney cancer? Is there screening for kidney cancer? Who are the right individuals to screen for kidney cancer? So I thought we'd focus on those three topics, and I'll do it in a bit of a summary way. Happy to talk to anybody afterwards for more details or any other information as well. So when we think about inherited kidney cancer, we think about breaking down kidney cancer development into three broad subtypes. One is inherited kidney cancer, where there is a identified genetic basis, genetic mutation in a cancer gene, for example, a kidney cancer gene, explaining the kidney cancer development in a patient and kidney cancer and other cancers in that family. So when it comes to kidney cancer, about 5 to 8% are inherited, though in some subtypes of kidney cancer, it's higher. It could be as high as 20% of kidney cancers. As you've heard, kidney cancer is not all one type of disease. There's different subtypes of kidney cancer. So the inheritance can differ. There's a range based on the subtype. We also see what's considered familial cancer families. And so when, for example, we do genetic testing in a family where there's lots of cancers and we don't find a genetic mutation, we still suspect that there may have been either some inherited reason for the cancers in that family that we just haven't been able to identify, or familial reasons for kidney cancer. So for example, we know that families have shared environments, shared diets, and could there be these other types of factors that led to an increase in cancers in a family? So that's termed familial. The majority, however, are what's called sporadic, so not explained by an inherited genetic reason for the cancer development. And then just a bit of genetics 101 to back to college or high school. When we think about this type of genetic testing, genetic patterns, it is really important to think about considering family history broadly. So family history becomes a really critical feature for lots of reasons when we're thinking about this space of genetics and genetic testing. And one of the big topics that we talk about a lot when we're doing public education or education for our patients and families is that it's often very common for, let's say, a woman who comes in thinking of breast cancer to think of just the breast cancer family history, or a patient that comes in thinking of kidney cancer to just think of kidney cancer family history. But it is really important to think of family history more broadly, thinking of all cancers in blood relatives on mother's side of the family and on father's side of the family, going up 3 generations, going down generations, and out to aunts and uncles and cousins. Because those patterns can be really helpful to think about genetic testing. And also when we think about cancer screening based on family history. So just really important to keep in mind. And when we're talking about this type of inheritance, it's about 50% chance of passing on a genetic mutation if it's identified to each child. So each child has a 50% chance of inheritance once we identify a genetic mutation. So who should consider genetic testing for inherited kidney cancer? These are some of the features that we look for to think about the suspicion that there may be a genetic indication for genetic testing. So young age at diagnosis, so kidney cancer diagnosed at less than or age 46. And then family history becomes really important. So more than one or more relative with kidney cancer or any other features. Again, so really thinking more broadly about what family history really means. The tumor pattern. So were the kidney cancers multiple in the same patient involving both kidneys, that can raise the suspicion that there may be a genetic basis for kidney cancer development in this patient or in this family. Unusual subtype of kidney cancer. And then other conditions, like as I mentioned, that sometimes that can be other cancers, but oftentimes it's just other conditions. So for example, particular skin findings, or potentially that a patient had, for example, a lung collapse and it was unexplained. And so just bringing some of this medical history to light can be very, very helpful for us to understand what might be going on and think about genetic testing. And then certainly if there's a known mutation in the family, then blood relatives would want to consider their own genetic testing to see if they inherited a cancer gene mutation. So as we think about the next question, so for the first question, can kidney cancer be inherited? Yes, a subset of kidney cancers are inherited, and there can be some features of that, which is what we just talked about. So what is the genetic testing for kidney cancer? And this goes to really thinking about the genetic testing process first. I thought I would give some context about what is the process that a patient would go through as they come to our cancer genetics program and are involved in the genetic testing process, and then think about what genes we would be thinking of testing for. So the genetic testing process, this is a bit simplified, but it is a multi-step process. So as we go through the patient being referred to our program by their doctor, having an appointment with one of our genetics providers, a genetic counselor, where family history is taken as well as medical history. The patient undergoes pre-test genetic counseling, so an understanding of what the genetic testing process is. Testing is conducted, and then return of results. Some of the details of those aspects involve, for example, family history and medical history collection. So as I mentioned, as much family history as can be collected is really helpful. So we go back to those features: maternal and paternal family history, generational history becomes really important, all kinds of cancers, different types of conditions. And when we say this, automatically, the question becomes, sometimes it's really hard to know family history. I can speak for my own family. A lot of the family is in India. And so and it's a very large family. So I don't really know, how some of the relatives may have passed away. And we hear this same sort of stories from our patients here, about somebody might say they had stomach cancer, but was it pancreas cancer? Was it a female that had uterine cancer? What was that? So we know that there's limitations to family history, and also talking about cancer in families, it can be a tough topic, to talk about. And so part of our education is really trying to break down the stigma of talking about cancers and having it be a much more proactive approach, that this is really meant for health benefits for the patient and their families. So, but again, as much family history as available is just really, really, important. And we work with what we have when it comes to that. Regarding the pre-test discussion of genetic testing, there are multiple elements that are discussed in the genetic counseling session to understand about this hereditary cancer genetic testing. This includes things like what does it mean to have cancer inheritance? What are the genes that are particularly relevant to the cancer of concern for the patient and based on their history and their family history? What are the options for genetic testing? Because these days we can test genes, a smaller subset of genes or a very large panel of genes, very comprehensive genetic testing. But there's benefits and considerations to those things. So really kind of understanding some of the nuances so that a patient isn't necessarily surprised or blindsided by results that they didn't expect, from genetic testing. Different types of results that can return from genetic testing and the impact in the families. We actually talk in detail about this genetic discrimination laws. This is a very big, important topic for patients to understand, which is that what is the federal law that provides protection for individuals that are found to have a genetic mutation? There are federal laws that protect in terms of health insurance discrimination, employment discrimination, but where there is no federal protection is for things like life insurance and long-term care and disability insurance. So having informed consent for genetic testing means understanding some of these things and timing the genetic testing such that if these are avenues that a patient is trying to pursue, go ahead and get things put in place, unless there's some urgency for the genetic testing, from a clinical perspective. So talking those things through becomes really important. Then we go ahead and order the genetic testing. So actually the testing itself is probably the simplest part of the process. It's the pre-test informed consent counseling piece of this. And then once the genetic results return, we go over and have a detailed conversation with patients about what was the result of the genetic testing, what does this mean regarding for the patient themselves about cancer risks that might be associated with that gene or conditions. What does this mean for the patient's blood relatives? So a major motivator for patients is their children. So what does this mean for my children, siblings, et cetera? We give recommendations for high-risk screening. So a genetic mutation is found. What does this mean for screening for breast cancer or colon cancer or other things? And we'll talk about what are the current screening guidelines for kidney cancer in just a moment. And then, of course, pursuing genetic testing in the family based on the genetic results. So the four main benefits when we think about what information does genetic testing provide. One is to help understand cancer risks. Second is to help guide medical management for patients or surgical management, to guide treatment and surgical decisions, and then identify at-risk family members. So there really is this ripple effect. When we start with one individual for genetic testing, there's a ripple effect. One family by family, it really helps to have a population level impact as we think about this going forward. So for example, many of you are familiar with von Hippel-Lindau as a hereditary kidney cancer syndrome, VHL for short. And so this is an example of, let's say, a patient comes to us with kidney cancer in their 30s, in their 40s, and we pursue genetic testing after the patient has, genetic counseling, and we have a result that comes back with a mutation in the VHL gene. What would we be talking with that patient about in terms of the cancer risks or conditions associated with VHL and the management of those conditions? That would be the topic of the discussion at the disclosure visit. So as you can see, while VHL is associated not only with manifestations for the kidneys themselves, there are multiple other organ systems that are affected that have impact from a VHL mutation. So this could include things like blood vessel tumors in the brain and the eyes, adrenal tumors, tumors within the inner ear that might affect balance and things like that, reproductive implications, as well as pancreatic cysts and tumors. Now, there's guidelines around how to address all of those things when it comes to VHL. So in terms of imaging, screening, et cetera. And again, the point is to be proactive. So if these were conditions that were going to develop or be predicted to develop for a patient, we really want to get on top of that, and get as much proactive as we can to identify and intervene. So again, some of these recommendations can involve early cancer screening or screening for these conditions, intervene as indicated, potentially help inform targeted therapies for a patient with cancer. And then for VHL in particular, childhood screening. So there can be childhood implications of some of these recommendations as well. So when we think about what are the genes related to kidney cancer, there are a number of kidney cancer syndromes, hereditary syndromes. These would be the genes that we would be testing for. And this is a busy slide, but mostly to show that there are various different types of kidney cancer syndromes that can be inherited. There are different genes associated with these syndromes. And so family history of cancers and conditions becomes really important when we think about how to align the patient's history, their family history, with the genetic information that we get back from genetic testing. So every patient's recommendations are quite personalized based on the information that we see from family history, personal history, and genetics. And there are multiple genes that are available for kidney cancer genetic testing. And oftentimes we can branch out from this to include genes beyond kidney cancer as well when we do genetic testing for our patients. And the final question is, should I be screened for kidney cancer? So this is a common question that we have from our patients as well. And when we think about this, first of all, for kidney cancer screening recommendations for those inherited syndromes. So when there is, excuse me, a genetic mutation identified that is then associated with the hereditary kidney cancer syndrome. So for example, we talked about VHL here. There are national guidelines that recommend cancer screening for those individuals. So abdominal MRI that is actually started at a young age, so starting at age 15. Excuse me. And so this MRI would be done every 2 years. And so as you can see, there are recommendations that are similar for other hereditary kidney cancer syndromes based on the syndrome itself. And so the abdominal MRI is usually the preferred method of screening in these syndromes, for patients with these syndromes, to be able to have that visualization of the soft tissues and limit radiation exposure. And the screening frequency can be important. So sometimes the screening is every 2 years, sometimes it's 1 to 2 years with this approaches, and sometimes it's a little bit longer. But as you can see, some of those screening ages are quite young. And so it really can make an impact in these families. But what about if there is no genetic mutation identified and there's a family history of kidney cancer? And so in this scenario, really the table to the right is just a summary way to think about this in terms of screening and when it comes to kidney cancer. So if there are no risk factors, no family history, no other risk factors, no routine screening is usually recommended. But if there's a family history, the first step would be to consider genetic counseling and testing. Because if a genetic mutation is identified with a confirmed genetic syndrome, the recommendations are, as I mentioned, there's guidelines around how do we screen for those individuals. If there's a strong family history and no genetic mutation, right now it comes down to an individualized plan. So it is about meeting with the patient, having the patient meet with their doctor to talk about the family history and really potentially discuss the pros and cons of kidney cancer screening so that the patient can make an informed decision. The question will become, will insurance cover that screening, because of the limited guidelines? And we really need to make progress in this area when we think about aspects such as familial kidney cancer or screening in general, beyond those individuals that have a genetic risk. So in conclusion, as we talked about, there's a proportion of kidney cancers that can be inherited, and knowledge of family history and conditions within the family can be very, very helpful for informing genetic testing to the best that you know that information. Bringing this family history information to your doctor to discuss if genetic testing should be considered. We really try to empower our communities and our patients to bring this information to your doctors. Current kidney cancer screening guidelines are focused on identified genetic risk. So that's really where it's focused. And we know that we need to make advances in terms of broadening kidney cancer screening approaches. What's the best way to do this with the promise of research advances? And how do we do that responsibly? And just very, very important to stay patient-centered in all of this, to offer support and empowerment to patients, families, and caregivers. And of course, that's who we're doing this for. We're doing this for the patients, for our caregivers, our communities, the public. We learn so much when we talk to our patients. And so that learning that we come is a two-way street. We want to be able to bring the insights that our patients give us back to our patients and our community. So we really thank you for those insights that you bring. I'll just end with the ways that you can, just if you want to scan that QR code for our cancer genetics program, we have a really great website, videos available for patient education, and happy to hear from you at any point as well. So I will, you want that QR code? Yes, go ahead. I'll leave it up for just a second. So, yeah, of course, not a problem. So thank you so much for your time. It's been really nice to be here.
Thank you so much. That was wonderful. And we'll have a panel at the end with a chance to ask questions. But our next speaker is Maura Harrigan, who's really an expert in nutrition, a question that comes up a lot in the clinic, and brought bags for all of us that we're going to walk through. But I'm so excited for this talk because it's something that I constantly am trying to learn about as well. So thank you so much for joining us.
Which button do I press? Green one. Okay, thank you. Hello, everyone. So I'm here to talk about food. It's fun. Exercise, even more fun. All right. In my many years doing patient counseling at the Survivorship clinic at Yale,
was there when we started the clinic back in 2006. And then subsequently working on various research studies and the School of Public Health. And these were lifestyle intervention, doing nutrition and exercise during treatment, all different cancer sites. So in all of these patient encounters I've had, what I've learned from patients is that receiving a cancer diagnosis can be, as we know, very disruptive. And, but it also can present a teachable moment. And I find most people, when they receive a cancer diagnosis, start to think about, well, how am I eating? How am I moving my body? And how will that affect my treatment and my recovery? And as I continue on into survivorship. So it's a wonderful teaching moment. However, as many of you find out, when you start asking questions and start doing your own searches, there's a lot of misinformation and it ends up being very confusing. So people do what I call a lot of Dr. Google searches. I don't know if we have to switch that now to Dr. AI searches, but there's a lot of conflicting information and it leads people to think we really don't know what it means to eat well. And I'm here to tell you, oh, yes, we do. And when you leave here, you will know what that means. And you'll have a little kit to start implementing as soon as you get home. So questions are carbs good? High protein, no carbs? Do I take turmeric? Should I do keto? And then to make matters worse, well, then what happens? We get a new pyramid. Even this confused me. I was like, where did this come from? Because one, we stopped using the food pyramid in 2011. So I was like, what are you talking about? And then they flip it over, which flies in the face of everything we know about evidence-based nutrition. But don't worry, I'll clear it up for you. First, you have to consider the source. Where are you getting your information from? And this is my public service announcement for everybody. All registered dietitians are nutritionists, but not all nutritionists are registered dietitians. Anybody can call themselves a nutritionist. There's no license, there's no degree. So when you're looking at sources, hey, who wrote this? Who am I talking to? And of course, your best bet is a registered dietitian. Just plug in the profession here. Thank you. So we do know what it means to eat well. And we call this evidence-based nutrition. You know, it's a solid science. And we don't talk about pyramids anymore. We talk about what does your plate look like? What does the food in front of you look like? And what is the proportion of the foods? So I'm going to ask you to think very differently about food now. You're going to think about, where does this food come from? Does it come from a plant or does it come from an animal? It's that simple, plant versus animal. And what proportion you have these foods on your plate matters. So we call this the new American plate because the proportions are different than what we typically do as Americans. We want 2/3 of your plate, the majority of your plate, to be filled with foods that come from plants. That's fruits, vegetables, grains, potatoes, rice, and just 1/3 from animal sources. And as I'm sure many of you in this room, when you think American plate, it's the reverse. It's like a big hunk of meat and then maybe some garnishing. So it's the reverse. This is what we call a predominantly plant-based meal pattern. The beauty of this, it's like a template. You can fill in any kind of foods you want if you have it in this proportion. Now, why does this matter? The key is the plant foods. Now, way back when Hippocrates had it, he said, let food be thy medicine. Somewhere along the line, we forgot that. And I'm trying to get everyone to remember to use this as an ally in your treatment. It doesn't replace all this phenomenal modern medicine treatment, but it supports it and it supports your body. So the key is the compounds in the plant foods that act as medicine. Number one is fiber, dietary fiber. And I'll show you how you find that in a couple of slides. Fiber only comes from plant foods. Fiber is Mother Nature's gift of health to our bodies. Fiber is Mother Nature's prebiotic, right? It's the substrate that your body uses to create a healthy gut microbiome. You've heard of that. So that supports your immune system. So it's fiber that feeds that. And now we're going to get into some other things you may not have heard of. We call them phytonutrients. Phyto meaning plant. These are compounds that are only found in plant foods. They're not, they don't have calories. They're not vitamins. They're not minerals. They're these very particular compounds, and there are hundreds of them. This is just a smattering of the names. And you can see they're very chemical sounding. But the beauty of it is each of those compounds is represented by a color, right? So different clusters of these phytonutrients impart the color in the fruit and vegetable. So now think in terms of colors, it makes it easy. So in the course of your week, you want to capture all these colors on your plate: white, red, orange, yellow, blue, green, purple. This is the best report card you can give yourself into how am I eating. Think about what colors did I have today? And believe me, it's very easy to say, oh, I didn't have any. Oh, gee, I should add some color. So every time you sit down to eat, every time you have a snack, say, is there a color here? So it's a very shorthand way to get at this very powerful science of capturing these phytonutrients. So when you go shopping, you say, do I have all my colors? Look in your cart. I hate to tell you this, but that's a game I play when I'm in the grocery store line. I look at other people's carts and I say, do they have any colors in there? So in your bag, there's creating a nutrient-rich kitchen. So I have a list of how to stock your kitchen, how to shop for these foods, and how to stock your kitchen to create this phytonutrient-rich kitchen. What's fascinating is that the foods that have the most power are your frozen fruits and vegetables. People find that surprising. Then canned, then fresh, if it's local in season. So this can be very economical. So I have in your handout how to stock your freezer, how to stock your refrigerator. These foods do not have to be organic, and they do not have to be non-GMO. Organic or non-GMO has nothing to do with the phytonutrient content. All right, so this is a very cost-effective way to capture these phytonutrients. So I have here in the freezer, in your refrigerator, in your pantry, in your spice rack. And in this handout there, all the samples of the phytonutrients are in red. So this, in all my years of counseling, I don't have much time to talk, but I would distill it down to what I call the biggest bang for your nutrition buck. What are the things you can do to improve the nutrition content of your eating? First is start filling your plate with 2/3 of plant foods. That's where you're capturing the fiber and the phytonutrients. And here's the next key piece: reduce added sugars. Right? We want less than 30 grams a day. That's about 8 teaspoons. And I'll show you in a next slide where to look for that. You would not believe how much added sugar is put into our food supply. Does anyone go to Starbucks on a regular basis? If you do, you're getting at least 80 grams of added sugars in one drink. This is one of the most enlightening things you can do when you go home, and you'll see how to find this in your on food labels. Reducing added sugars is key. And then this is often a surprising point. Shift your calories to earlier in the day. Do a hard stop to eating. I say 7 p.m. That's negotiable. You can individualize that. But you have to clean out all that eating that's done too close to going to sleep. Right? You have to get rid of that and move those calories earlier in the day. And that creates an overnight fast of at least 12 hours. Okay, at least, ideally 16. That's a lot, but 12 hours. So stop eating earlier, create an overnight fast, And then the first meal you have the next day is called break fast. Oh, that makes sense now. Like it has a name for that purpose. I can't tell you how powerful that is. Now, here's some consumer skills. You're familiar. I want you to all leave here and be label readers. The two most important things, I always say these food labels were created by a committee because there's too much information on there that you don't know what to do with. So the two important things to look at is I had that circled. How much dietary fiber is in that food? And you're aiming for 30 grams a day. And a high fiber food is considered 3 grams or more per serving. Now, on the flip side of that, you want to look for, there's the added sugars. You know, this was just recently added to the label by the FDA, not too long ago, a few years ago. It wasn't there. It was under total sugars. Now, total sugars includes naturally occurring sugar that's in fruits and some vegetables. That's fine. It's added sugars that's put in by the food manufacturer that has no need to be there other than it tastes good and we like it. So you can see that breakout under total sugars, it says added sugars. That's what you look for. Again, your goal is under 30 grams a day. And as a point of reference, a teaspoon of sugar is about 4 grams. And I challenge you to go home and go through your refrigerator and your pantry and your freezer and look at your food labels and look at how many added sugars are in your kitchen. And if your goal is to keep it under 30 grams a day, most of you will be very surprised how much added sugar is in your kitchen. Okay, so those were the highlights for nutrition. I tried to distill it down. It's always a challenge to talk to a group because everybody eats, right? And everybody has their own set of questions. And I'll be happy to meet with you afterwards to answer those. And I also put my email address on that handout so you can email me questions too. So now we're going to switch gears and go to physical activity goals. And again, in your handout, in your little toolkit, there's a handout for physical activity goals. Now, the importance of exercise can't be overstated. As you know, being diagnosed and treated for cancer creates this unique fatigue. It's called cancer-related fatigue. And it's not cured by more sleep. It's not really well understood. And it can linger well after you're done treatment, a year, 2 years. And it's physical activity that will help speed up that recovery and give you back more energy. And the first thing in terms of physical activity is taking a break from sitting. And actually, I'm going to ask you all to do that right now. Everybody stand up. See what that feels like. Stand up, twist a little bit. You've been sitting for too long, right? Feel good? Okay, now reach into your bag, and there's a resistance band underneath that. So as we're taking a break from sitting, we're going to do a little resistance exercise. And so you're going to keep the resistance band in each hand. Oh, look at that. Napkins work well too. Very, very resourceful. Feet shoulder width apart, arms straight out. Now just pull. Oh, doesn't that feel good? Go back. Just pull. You must work out. Okay, that's how easy this is. All right. Now, easy. Strong. Okay. Okay, you can sit down now. And when they sit down, see how different your body feels just from taking a break. And the energy and the mood changes. So taking breaks from sitting is so important. And talk about the strength training. The cancer treatments do direct hits on our muscles. We lose muscle. Not only that, the natural muscle loss we have. So this strength training is so key, and that's why we incorporate it into all our research studies. And it's 2 times a week. about 2 minutes. And we do home-based stretching. You don't have to go to it. You can do it at home. Resistance bands. And again, in your little tab are resources to find out these exercises and also so, but the key thing, in addition to getting up and standing and doing your strength training, is walking. I can't tell you how powerful walking is. And walking is a form of medicine. And the goal is to accumulate 150 minutes a week. So every little bit counts. So things like parking farther away and walking in adds up, right? So I like the idea of 150 minutes a week because every little bit adds up. 10 minutes here, 15 minutes here. Maybe you get a good 30-minute walk in. And what we also encourage people to do is as you know, when you're diagnosed and friends and family say, what can I do to help? You say, oh, become a walking buddy, all right? I need to walk. Be the one who says, okay, call me up. Let's go for a walk. Get me up out of the chair and let's go walking. I can't tell you how powerful that is. So in all our research studies, we have people line up walking buddies on a calendar in the week so that they accumulate this 150 minutes a week of walking. Now, the thing is, how does the nutrition and exercise benefit the body? And there are these three major mechanisms that nutrition and exercise assist in the body. One is reducing inflammation. So in our lean study with nutrition and exercise, we found our participants lowered their inflammatory marker, which is C-reactive protein, by 30%. It was our first finding. And we always joked like, that's drug-worthy. That's a drug-worthy effect. And we joke that if we were a drug, we would have been on the front page of the New York Times, but it's nutrition and exercise. People are like, what's so special about that? It's special. You can reduce inflammation. In terms of metabolism, I really think this is the key where lowering those added sugars play a key role because that lowers your circulating levels of insulin, right? And that's a key health promotion that we want to do. And then immune function, that's where the fiber comes in and being a substrate for your gut microbiome. So this is a very supportive role of nutrition and exercise. And I know you just heard about genetics, but we call this epigenetics effect, where it affects the body surrounding all these other functions. So it supports your body. So now I'm going to get a little cautionary tales here because what I just outlined seemed pretty straightforward, right? Predominantly plant-based, increase fiber, lower your added sugars, stand up, walk, couple of strength training. But the thing is, there are a lot of obstacles in our way to do this as a society. These are real challenges, and the challenges are by these billion-dollar industries. These are big businesses that work against us. One is the business of ultra-processed manufactured foods, which is readily available. And the other is, I'm going to be cautious here, is dietary supplements. So as you know, we are surrounded by ultra-processed foods. My favorite is the drive-up window. Okay, so this is what I call a toxic food culture. These ultra-processed foods or fast foods are chock full of added sugars, salt, saturated fat, and no fiber and no phytonutrients. But this is what's so easy to access. And I guarantee you, anything you get through a drive-through window is an ultra-processed food. But you can also identify it by ingredients list. Now, I challenge anyone to read this list and let's shout out a guess. What food do you think this is? And it reads like a chemistry exam. Okay, that's getting there. Give up. Pop-Tarts. All right. So the easiest way to identify an ultra-processed food is to look at the ingredients list. And if it reads like a chemistry exam, it's an ultra-processed food. That ingredients list, when you break it down, it has 5 different sources of sugar, 4 different sources of fat, 9 different food dyes, artificial flavors, and 7 preservatives. Okay, we all agree that's an ultra-processed food. And that's very different from our predominantly plant-based plate we were looking at, right? With 2/3 of our plate being filled with plant foods. So before I leave ultra-processed foods, I just want to say, to eat well in this food environment that we live in, you have to be very intentional. It's a decision. You have to find your way through this food supply. Now, I want to get to dietary supplements, because there's a very high usage of dietary supplements among cancer patients. We looked at the close to 500 patients who were enrolled in our studies, and over 80% of them were already taking dietary supplements that they weren't necessarily reporting to their medical team, but they reported it in our study. All right. 80%, and over 50% of them were taking 3 or more. Right, so high usage. And when I talk about supplements, I'm talking about over-the-counter vitamins, minerals, and herbal preparations. I'm not talking about something that you with your doctor have decided he prescribes or he or she prescribes a necessary nutrient. That's okay. That's the way it should be done. I'm talking about when you walk into CVS and you say, oh, maybe I should have this. It's over the counter. You can just grab whatever you want. That's a problem, because people's misconceptions are that if some is good, more is better. And actually, supplements, they're better than food. And since it's over the counter, of course it's safe. And I've been told, I've heard patients say this, that it will protect against cancer recurrence. So let's go through each of these items. More is better. No. Supplements work in small amounts. Vitamins were originally discovered to correct deficiencies, so they're needed in small amounts. More is not better. When you get into higher amounts, and every vitamin and mineral has an upper limit that we know that's safe. Many of the over-the-counter formulations in CVS, in the grocery store, are higher than the tolerated upper limit. When you get into these higher doses, that supplement starts acting like a medication, and it interferes with prescribed medications. They compete because they're processed using the same pathways. Are supplements better than food? No. Those pills, that's an isolated supplement, often at very high doses. When you have that nutrient in a food, the food has what we call the food matrix, which has all supporting other nutrients in it that help enhance the absorption and utilization of that nutrient. So eating an orange is infinitely better than taking a vitamin C supplement. Right. Now, here's what many people don't realize. These over-the-counter supplements are not necessarily safe. There is no FDA approval process or safety testing before any of these supplements come to the market. And many people find that surprising. And the reason is the law behind how these are regulated. The FDA regulates dietary supplements like a food, yet these supplements act like a drug. So it's a mismatch. So considering all the above, the answer would be, would this protect against cancer? And the answer is no. That predominantly plant-based plate? Yes. All those phytonutrients and fiber foods? Yes. So I really want to, and I bring this up and I state this strongly because it's such a high usage among cancer patients. So just to kind of bring it back, I wish I said this clearly, but very pithy statement. So the goal is to eat real food, not too much, mostly plants. Now, Another saying I'm fond of is that it's an everyday thing to eat well and move more. Every day is a new opportunity to move more and eat smarter. Because as we know, it's hard to do every day. Some days are easy. Some days are more difficult than others. And some days you just can't do it. And that's okay, because it doesn't have to be perfect. It doesn't have to be 100%. It's not, I'm either doing it or I'm not. Anything you can do helps. And we often quote an 80-20 rule. 80% of the time is good enough, right? 20%, that's all your fun stuff. And anyone who knows me knows that my 20% always includes a jelly donut. Gotta have them. So in closing, this is an inspirational picture by one of our study participants up at Dana-Farber, who said when she was initially diagnosed with breast cancer and had reconstructive surgery, she said her goal was to be able to do, when she's all said and done, to be able to do a handstand on the beach again with her family. I have to disclose, she knew how to do one before the cancer diagnosis. It's not like, but she gave herself the goal. And that's what I found with the study participants and all the patients I've seen in survivorship clinic, that when you do eat well and when you do move your body, it's a sense of empowerment in a scenario where you don't always feel like you have much power. You know, you've been given a diagnosis and you're going through all these treatments. You show up where you're supposed to, but and do what you're told. But this nourishing your body and moving your body really gives some sense of control in your life and empowerment. And I hope that you leave here feeling that way too, and take your little toolkits and start putting them into action when you get home. Okay, thank you.
Thank you so much. That was a wonderful talk, and such an important part of it. And I think more and more the science behind this is being understood. There's some phenomenal, not to nerd out too much on immunology, but some phenomenal work done recently at University of Pittsburgh about how actually regular exercise, this was in mouse, affects our gut microbiome, leads to more formic acid, and actually helps immunotherapy work better. So there's definitely these mechanisms, biological mechanisms for this, which is really an exciting new field. And so to round off things, I'm so excited to have our last speaker, Dina Battle, who you've seen, I think, some of her charts a few times throughout the day. She runs KC-Cure and really has made it a point to have the patient's voice be a central feature as we think about research and clinical development within kidney cancer, has had tremendous impact in this domain, and has really become a fixture within the community. So thank you so much for traveling here to join us.
Thanks, David. I'm really honored to be here. And, when David invited me to present, he gave me this topic of building a supportive RCC community. And I don't know if we actually had the same idea of what that would mean, but either way, I'm going to tell you about my work and the work that KC-Cure is doing in building supportive RCC communities. And I'm really talking about online communities. Just out of curiosity, how many patients or caregivers in here are part of an online community? Yeah. So if we think about the growth of online communities, it really goes back to the 80s with blogs. When my late husband was diagnosed with kidney cancer, we started first with a Caring Bridge page just to keep you updated. He was a very funny writer, so we turned it into a blog. And after 4 years, we actually had thousands of people following this blog and reaching out to us. And then we became active in a group called ACOR, which was an old-fashioned listserv. And today that's known as Smart Patients. Some of you might have heard of that. When I started KC-Cure in 2016, one of the first things I said we had to do was we had to build these online communities. And we primarily our communities are on Facebook. And the reality is almost all of the most active communities are on Facebook. It is a platform that has 2.8 billion users, 6 million health-related groups. there's at least 50 unique kidney cancer groups. And honestly, I mean, I probably made this slide a long time ago. And they're adding 200 new members per day. So these are really active, growing communities. This is from a study that is not David Braun, but it's different Braun. This is from 2019, and this was a survey of cancer patients. 80% of cancer patients reported using a social media platform to connect with peers. 49% joined a platform as a result of their cancer diagnosis. So really, today, the primary source of information for patients is other patients. And there's great community benefits. This is another research study looking into different benefits. We know that there's psychosocial support that's really helpful, but it's also increased access to information. And just to give some examples, here's something you would see. This is someone posting, they had a stage 3 mass, they just had their scans, their NED, and they're excited. And you can see all these responses right away come up. This says a really high engagement rate. And that feeling of community, of not being alone, is so important to patients and to caregivers. Here's another example. And a lot of times doctors will ask me, well, I can understand why a patient would join a community early on, but why do they stay? And the reason is because helping other people helps us. It makes us better understand the thing that we're going through. And this is something called the helper therapy principle. And it's actually the basis for groups like Alcoholics Anonymous and Weight Watchers. So we know that this is a tried and tested thing. And this is what helps keep these groups together and supportive. It's also a great source of information. I love this because this was, a woman who was diagnosed with RCC. It was low stage, and she wants to know if she can have a baby. There's not a whole lot of premenopausal women out there diagnosed with kidney cancer. If you're a doctor seeing a patient like that, you're going to say, yeah, we think so, right? But to hear this woman, she gets 3 women responding saying, I had a baby too. And that type of reassurance is something that you really can't get in any other source. You can't get that from AI. And that is real meaningful, important information. And over time, what's happening in the group, it's not just individuals learning, the group is learning. Okay, it's incidental learning, which is unplanned or unintentional learning. So as people share these things, they learn something and then they'll repeat it. And so the group is becoming smarter over time. And it's actually really accurate. And just here's an example, because a lot of doctors worry about things like this. Someone posts something, should I take 300 milligrams of melatonin before radiation? I don't even know why that's, I have no idea why this person asked that. But you can see that the response is, you should talk to your doctor about that. People aren't chiming in and saying, no, I take 400. Everyone's just sort of like, I don't know, right? Why did you ask that? So we really, when someone posts a question that doesn't belong in a group, the most common response is just, they don't engage. And there's research to support this as well. And this is based on this concept of wisdom of crowds, which comes from Sir Francis Galton, but also James Surowiecki wrote a great book talking about how to build wise crowds. But even a research study that was done looking at engagement in social media found that accuracy rates related to conversations about medication, accuracy rate was 78%, treatment protocols, 75%, and management of side effects and symptoms, 80%. So the information exchange is actually very accurate. But of course, there are risks. And the big things we hear about a lot today, disinformation, misinformation. And the difference between those things is that disinformation is false information spread with the intent to deceive, whereas misinformation is false information spread without intent to deceive. Now, when we see these things in our community, it's actually important not just to think about the presence of disinformation or misinformation. It's really important to think about how does it impact people, right? Because you could have misinformation. For example, someone could say, you can cure cancer with vegetables. right? But if someone eats more vegetables, we're not really worried about the harm associated with that. So really we want to think about like, how is this misinformation or disinformation going to impact? So we look at things like frequency, how often is it being shared, the intensity, how many people see it or care about it, how do they feel about it, and do we think it's changing behavior, and is that negative behavior? Is it a negative impact? So here's an example of disinformation. Okay, someone posts, anyone who's in a group has seen posts like this over and over again, right? The frequency is high. I use Rick Simpson oil to heal my cancer, to cure myself. The engagement is low and the comments are low because most people are going to approach a post like this with skepticism as well. They should. They aren't going to change their behavior because of this. But the real problem with disinformation today and online social media is that most of it is coming from predatory profiles, and they're not even there to sell fake cures. They're there to steal your identity. And that is something that we care about deeply, and you should too. So this is a major impact. It's not a health impact, but it certainly is a toxic impact for cancer patients and their loved ones. So now we're going to talk about misinformation, which is when the intent is not to deceive. And this is harder. So this is a post. Can kidney cysts turn into tumors? Doctors? Shaking your head, yes, no, yeah, no. Surgeons? I don't know. No one wants to answer that. Okay. Let's see we're going to see what the group says. This is what happened in the community. This is not a case of cure group, but this is an example that we use. So this is the group expert of this group. Complex cysts have a great likelihood of turning cancerous. Okay, simple cysts do not. This is coming from, this is another patient. And then we get someone saying, I had a simple cyst and they just watched it and it did turn into cancer. So yes, it can turn into cancer. And multiple other people say that theirs did too. So if we look at this, the question in the group was, can cysts turn into kidney cancer? 6 out of 13 commenters replied with a definitive yes. You had a group expert saying it's high likelihood. 5 people claimed a personal experience with a cyst turning into cancer. No one said no. So really, the takeaway here is that cysts can and do turn into cancer, right? And I think I can get the doctors to agree that this is probably a form of misinformation. Can I get, yes, okay, yeah. Correct. I love that you said that. It is so correct. It's so close to being correct, but it's just not quite. And now we see the real problem. Now we see the harm associated with this. And what are those harms? How many people saw this thread? This is a group of over 6,000 members. 400 people were estimated to be reached by this post. 20 people engaged, 13 comments. And we see harms. It causes distrust of the cancer care team that those patients are seeing. It might lead to excessive testing, unnecessary anxiety, decisional regret for a patient who's perhaps on active surveillance. So here's another misinformation example. My doctor told me that kidney cancer usually doesn't go to the brain. It shows up in the lungs first, okay? This is not misinformation, by the way. This is just an example I'm gonna give, okay? This group member is someone who was diagnosed, they had a stage 1, small renal mass, low grade, clear cell, and they've been free of disease for 2 years, okay? But now we get the responses back, okay? My first recurrence was in the brain. So be sure to watch for symptoms. Kidney cancer can metastasize anywhere. I had a craniotomy and then 3 rounds of IL-2. This is a person who was diagnosed many years ago, okay? And now we think about harm here. So now this person is saying, I'm gonna call today and ask why I'm not getting brain scans. So what we're seeing here is we're seeing statistical bias because this is a group that has all different stages of kidney cancer, right? And we're seeing a little bit of context bias, people who are diagnosed at different times. And now we see harm. This person does not feel safe about their surveillance that they're getting. They think, why am I not getting MRIs? But actually, what their doctor told them in the first place was correct. It was correct. And so we can sort of really see the harm associated with this. And we can also see group harm, right? This is a group, 6,300 people, 400 and 450 people saw it. And now we have incidental learning and social proof that's in the negative, right? Because now people see this and they start repeating it. So the next person that comes in and says, can it go to your brain, even if you had a very low risk? Is it going to show up in your brain first? People will say yes, because they've seen this being repeated. So when we talk about misinformation, not disinformation, the challenges we have is most of the time it's derived from a place of authority. This is someone who was told this by their doctor. It's driven by compassion. This is not a predatory seller. They're sharing this information because they care and they want to protect other people. And it's reinforced by uncertainty because there always is that one outlier case. There is someone who did have cancer metastasize to their brain first and only. It's a very rare circumstance, but when you see it once, it feels like it's a lot more common. So these are some of the things that we're doing, Casey Cure is doing, to kind of counteract these things and to build wise crowds. So characteristics that we strive to achieve in our communities, we want our groups to always be growing, which means that they're adding new people, but they're maintaining an active presence and they're engaged. So these three characteristics, there's research showing that this type of group growth and engagement causes communities to continue to thrive. And then how we're protecting, we want to increase authenticity. We want to make sure our communities are representative and that they're independent in the information that's being shared. And I'm going to talk about those things a little bit. So the first thing we do is we manage membership. A lot of our, the work that we do is keeping predatory profiles out of the group in the first place. And we do that by asking entry questions. And if we're not sure based on the entry questions, then we would go in and look at their profile, and then we might do message verification. And if we can't ensure that a person is authentic, we don't let them into the community. So this really helps ensure that we are just bringing in real kidney cancer patients, caregivers, and loved ones. And then we also use keyword notifications within our community once they're in to kind of monitor and watch just in case someone were to slip through. And since we started doing that, we put those measures into place 3.5 years ago. And we now block or decline about 23% of the requests. And since we've done that, total posts of disinformation are less than 1% of our total posts and comments. And so we know not only are we keeping people from seeing all those annoying spam posts, but we're also protecting privacy, which is something that's really important. And we also created group structures that help reduce that statistical and context bias that we saw in those misinformation examples. So we started out, we added a group just for patients with localized disease. We had an all-comer group, and then we broke it down into metastatic and stages 1, 2, 3. And then we actually added a small renal mass group because we had so many people coming in prior to even having surgery that were getting misinformation for someone who had, say, a stage 3 disease and they were getting adjuvant therapy. And these were people who might have a small renal mass that honestly would be a perfect candidate for active surveillance. We didn't want them to see all this messaging that might change their thinking on that. These groups are sequential. If someone joins our small renal mass group and then they get surgery and it is positive, they can join the 1, 2, 3 group, but they can stay active in the small renal mass group as well. And by having this type of sequential movement, we sort of have a more accurate depiction of statistical realities in RCC. And then we also have groups that are specific for different subtypes. A good example I like to use here is patients who have upper tract urothelial carcinoma. So they'll join a group of patients who are primarily renal cell carcinoma, which is the most common form of RCC. And they might say, hey, my doctor said I should get upfront chemotherapy before surgery. And they'll get 50 messages back saying, your doctor is wrong. Like, you need to get a second opinion. It terrifies them. But in reality, if you are a patient with upper tract urothelial carcinoma, you should get chemotherapy up front. So by specializing the groups, we also can improve the information that's being shared. And then we're doing a lot of research and looking at different moderation techniques to address some of these types of things. So we're identifying shared misinformation trends that we see. And then we work to develop accurate messaging, sort of acknowledges some of those problems. And we reinforce and repeat that messaging. We use the same social reinforcement that we see that causes harm. We use that in the opposite way. And probably the best example I can use here is in biopsy. Anyone who's part of a group, you might have seen there's a lot of warnings against getting a renal biopsy. And we've been able to develop better messaging to reduce that type of misinformation. And we can actually compare and contrast with other communities to show that if someone posts about getting a biopsy, we can show that our responses no longer include 50 or 60 warnings, that we have enough people to sort of reinforce and say, sometimes biopsy is necessary, it's safe if you need it, that type of thing. So we can see that we actually are making a shift in communication. So this just kind of show where we are since we started our communities. We have 11 different communities today with over 14,000 members. So, they're continuing to grow, and I think we'll always be continuing to evolve and shift to kind of address these different changes in care. And I'm just gonna, this is a QR code. If anyone is interested in joining our communities, this will take you to our page that shows all of our different communities. I guess I would end just with a message to patients. I think these communities are so crucial and important. I think connecting with patients, I know what it meant to me, to my late husband, to our family, and I'm sure, for you, that there are great communities of support. While I do think our case of care groups are the best, I certainly don't think anyone needs to leave a community of support that they're in, but maybe by being aware of some of these biases and, some of these types of misinformation that can occur, it can make you think differently, watch for those things, and also be a better participant in the group as those things are being shared. And certainly for the doctors here, I hope this is educational and informative for you as you think about counseling your patients post-treatment and during treatment. Thank you.
Gary as well. Everyone join at the panel, and I know we're running a little bit behind, but hopefully wrap up in the next 15 minutes or so, but have a chance to ask questions from this wonderful panel on the genetic risks of kidney cancer, nutrition, and about engaging in a kidney cancer community. And so with that, I'll kind of open it up for questions.
You guys don't want me to sing. Question.
We have one in the audience so far.
So for people without an identified, who have risk factors like a family history, without an identified genetic syndrome, who have familial cancer, what screening tests do you think might be reasonable? Because I think there's a lot of debate, and it's difficult to understand what tests may be covered by insurance, what might not be covered by insurance. Is a simple urinalysis sufficient? Looking for blood? Is an ultrasound okay? What would the right approach? And then how frequently should it be done?
That's exactly the question, is that comes up in that scenario of, I have a family history, of, let's say, kidney cancer and no known genetic mutation identified. And this is where that individualized plan approach comes into play. So there are different ways to think of testing for potential suspicion of an abnormality in the kidneys. So, for example, checking the urine for blood, for microscopic blood. Very kind of crude way of looking at that, but it's non-invasive and potentially, you know, could be useful. What about a kidney ultrasound? Once again, there's pros and cons to thinking of, you know, just an ultrasound-based approach for imaging of the kidneys. But again, it's potentially less expensive, so to speak, than an MRI would be. So we think about modalities like ultrasound, CAT scan, MRI, and each of them have their own, you know, trade-offs, risks, and benefits. The question comes down to what's really being picked up, what's the sensitivity and the specificity of these tests for actually leading to an identification of a kidney tumor that could be potentially a cancerous spot, you know, on the kidneys. And so this is why this discussion becomes so important. It ends up becoming a shared decision between the patient and the physician to arrive at a plan that would be that the patient feels is acceptable to them, and understanding the potential risks or possibility of not identifying, you know, let's say kidney cancer. So this is how a lot of the population level screening guidelines have come into effect. For example, mammography for breast cancer screening, or colonoscopy for colon cancer screening. Is studies had to be done to really identify how do the tests perform, what are the test characteristics, and then what does that mean in populations for identifying tumors? What's false? What could be identified like false positive? What's a false negative? So having that discussion becomes really, really important. It's very individualized. And again, we don't know if insurances would cover it. So that becomes a factor, you know, in those conversations. So.
Done like after they were diagnosed and nothing was found then. As things like evolve with time and say it's 10 years down the road, are there ways to like revisit it? Or I was even thinking about when my husband had his, and I know there was nothing found at the time, but since then we haven't like had any other discussions regarding it.
Yeah, absolutely. There is updated genetic testing. And what does that mean? So updated genetic testing can mean potentially new genes that are identified that are linked with cancers of concern. But there's also updated technology. So even within the genes that we may have tested previously, are there advances that can help take a deeper look at those genes for, you know, what might be leading to a cancerous process? So those the genetic molecular laboratory type technologies improve over time as well. Typically, we say if it's about a 10-year period of time between when the original genetic testing was done, it really could be worth it to come back and meet with a cancer genetic specialist and just ask, you know, has there been an update that we should be thinking of, you know, and maybe more family history has also come to light in different ways that could also help expand the views of the genetic testing. So about 10 years is about right, you know, to think of updated testing.
So this is a question for Dina. Thank you for your presentation and for everything you do. I learned a lot. My question relates to how the world is changing. So I think that until COVID, actually, we had very active support groups, also both for surveillance and for patients with metastatic disease. We would go, we talked with people, we had engaged social workers. It never really came back after COVID, part of that due to financial constraints, I think, and part of it due to the world changing. So my question is whether that's a local problem or is that something that's happening nationally? And do you think the online forums are a good enough surrogate for support groups?
So to be honest, I mean, I'm surprised you had active groups even before COVID. I think, you know, like I said, even my husband was diagnosed in 2009. Okay, so and we lived in Washington D.C. It wasn't exactly a small area. To be able to find an in-person community just for kidney cancer patients I mean, it just didn't exist. There certainly were cancer communities, but it would be primarily lung and breast, the most common. So I think it's something that's been declining for some time. I mean, people's time to be able to travel to a place, honestly, even just to find time to all come at the same time, I think has declined. So I think online is where where everything is sort of headed. And I think that is, I wouldn't say it's a surrogate. I would say it's its own thing. I would say it's its own unique thing. It can certainly exist with the addition of in-person meetings. I think in-person meetings like this are important, 100%. But I do think having that day-to-day connection with other people in the same situation is really crucial, because you really need people at certain junctures and moments, not just at that meeting, right? It's the day before the scan. It's the day after the scan. It's being able to reach out and know that someone knows exactly what you're dealing with in that moment. And that can't really be achieved in an online or in an in-person community. It is, I'm just saying, every 2 to 3 months is not going to be the right scan time for everyone. I mean, if you could pull that off, that would be impressive logistically. Yeah, no, that's what I'm saying. This is an addition. I think that you absolutely can, it should be part of it. But I think you need the online community that gives you that instant connection at times.
Yeah, I like that idea of not being an either or. There's probably, different roles, kind of an in the moment role, and then there's also sort of a big gathering role as well, which is, I think, different but both important. Good. Other questions? Okay, well, I know it's late in the day, so I want to thank our panel. This is just a wonderful set of talks. And just the final closing remarks, I want to thank my co-hosts, Harriet Kluger and Pat Kenney, for helping us put this on. All of our speakers who are wonderful. Cure, who really helped with the organization of this, and then Renee and Emily on the Yale side. And most of all, thank you to all of you for spending your Saturday with us. I really appreciate it. And it was, hopefully it was helpful. The last thing I'll just say is you'll get a link to a survey. That's really helpful. This is the first time that we're doing this, but think about what was helpful, what wasn't helpful, how you might change things in the future. Hopefully we can do this again, but really value your feedback. So thank you everyone for coming. It's just something to say.